Great. And Nancy, if you don't mind spotlighting me, I don't know why it doesn't let a host spotlight itself, but it's always a challenge.
Happy to do so, but I think you need to make me a co-host.
Oh, you're not a co-host. Okay.
Yeah.
How awful. Thank you so much. All right, we're going to get started. Good morning, everybody, and welcome to the second meeting of the California Disability and Aging Community Living Advisory Committee. We're going to give folks just a couple seconds to settle in as I'm seeing the attendees populate. All right. As always, we'll start out with a few logistics reminders before moving into the formal agenda items. This meeting features American Sign Language interpretation as well as closed captioning. To enable captions, please select the closed captioning icon at the bottom of your screen and you'll see subtitles pop up. Please refer to the California Health and Human Services Agency Community Living webpage to view meeting handouts, recordings, and transcripts from past meetings, and certainly items will be archived there for this meeting when they become available. Please note that there are two opportunities for public comment around, we're shooting for around 11 and 11:45 a.m. today. If you're joining us from your computer, please use the Q&A or raise hand feature to be added to the queue. And for those joining us by phone, please press *9 and we will call out the last 4 digits of your phone number and open your line to hear from you. At this point, I think I'd like to turn it over to Health and Human Services Secretary, Dr. Mark Galley, to provide a brief welcome.
Fantastic, and good morning. Thank you for joining us this morning, Kim, Eric, Claire. Thanks for putting together what I think is going to be a tremendous discussion through the agenda. I wanted to take a moment first to welcome all of you back. Since the last time we came together, that inaugural meeting, so much continues to move and change. Today, I know we're going to focus on some of the very important historic investments in community living, in our aging and our disability communities across the board. But before we get to those exciting parts, I do want to take a moment, because of the time we're in, to just call out where we are as a state, not just what the state government is doing or local government, but what all Californians are facing and going through. I think it's hard to say that it's historic always, but I think all of you know that what we are facing with the raging wildfires in certain parts of our state, where the entire state is vulnerable, people not just losing home and property, but being isolated and displaced once again, those with functional needs, older Californians with chronic health conditions, etc., are particularly vulnerable. And I appreciate the colleagues throughout HHS, state government, Cal OES, our local partners who are doing so much to make sure that needs go identified and met as quickly and soon as possible. This in the face also of what is really a long-term chronic disaster that's just getting worse, which is our water and drought situation in the state and the impact on already hard-hit low-income communities that depend on agricultural industry and frankly all of us for our food and our water, and knowing that the in particular impact on our communities, our most vulnerable communities, is real. And then the ongoing year and a half plus now condition with the pandemic, and the fact that I think in many ways the last time we came together we were looking forward to the improvement that we saw going into June 15th, that we were at historic lows for infections, for the impact on our healthcare delivery system, that our entire infrastructure around COVID was strong and robust. And now just, few handfuls of weeks later, we've seen 14-fold increase in cases, test positivity go up by 10-fold. Our hospitals surpass that summer surge total. The good news, though, at the moment is we have seen now about 2 weeks of case rate flattening, plateau, not a peak and a return downward, but an actual plateau of cases in statewide. But we know that COVID has not been a challenge that is felt equally at the same time throughout the state, and that there are communities that escaped the wrath of COVID previously, some of our far north communities where services and supports are already difficult to access. It's now being challenged even worse. My heart and concern and effort go out to our brothers and sisters in Del Norte and Siskiyou and the northernmost part of our state, where their health systems are being challenged and tested in a way that other parts of the state are not currently feeling. And it leads me then to, well, what do we do about it? And I'll never miss a chance to emphasize what we can do personally, what we can do in our families and our households and in our communities at large. But this begins with really paying attention to the two most important things at the moment: your own vaccine status and wearing your mask, and making sure that as you're moving around in your day-to-day life, interacting in settings that you normally maybe took your guard down versus last winter, it may be time to consider putting it back up, to making sure you don't leave without your mask, that you're wearing it indoors, even outdoors when you're in crowded areas, and that you do make sure that you yourself decide to get vaccinated if you haven't, and then pay close attention to what is a fast-moving target on recommendations for additional doses. Many of you saw that those who are designated immune compromised have been approved to get a third dose of the vaccine, the mRNA vaccine, that we're awaiting the implications for those that received the Johnson & Johnson vaccine, and that there is an important fast-moving conversation about whether an additional booster or third dose will be needed for all Californians at some period of time. We heard yesterday that it might be 6 months after you were fully vaccinated. Just before that, we were hearing 8 months. We're in active conversations with our colleagues at the CDC to understand the science, working with our own health systems that are studying the same thing among their healthcare workers, so that we can make a thoughtful recommendation based on the guidance from the state for the state of California. So stay tuned on that, but something will be coming out very shortly around that recommendation, and we will make sure through our normal channels of communication, we get that out to all of you. But I come back to that important message that it's really, I loved one article that said, vaccines are great, but masks make them better. And I think that is very true, that together these two tools will help us not get through only get through the short run, but get through what we all anticipate to be additional waves and surges coming to our state in the future. So with that, not always so uplifting message, but very important one, I want to move to just say that the budget that we were privileged to be a part of and pass, it doesn't have everything everybody wants, but it has a whole heck of a lot of stuff that is going to really advance our collective work towards equity and improving and closing health disparities and dealing with some of the heartbreaking conditions we all watched take hold during the pandemic. And it gives us the tools to do something about it. And I just want to commend Kim McCoy-Wade, Will Lightbourne, literally hundreds of people at Health and Human Services who for a long time not only helped build the state's official budget, but also put together a very forward-leaning, aggressive, large-scale, innovative home and community-based services plan for the state. And as we await the final approval, I know Will is going to present on it some today, that it really is these things coming together with other opportunities that are popping up along the way, where we can not just advance resources and programs, strengthen ones that exist, fill gaps for those in those areas where there are gaps, and work on things that you don't always get to work on. Things like infrastructure, things like the workforce. We all, and I know whether it's in this area or in so many other areas, behavioral health, healthcare services, social services, where we have major workforce gaps, we now have some real resources to invest in generations of workers in those areas, to not just create what we have today, but to improve the types of jobs that we have in these areas and ensure that the wages those workers are paid will keep them in the work, keep them happy in the work for a long time to come. And I always want to come back and spend a few seconds on the tremendous work our agency, along with other agencies, BCSH in particular, are doing on housing and homelessness. We know that it's going to take historic investments to tackle a historic problem that has brewed for years and decades, and we have resources now to make an important dent, not just in the Band-Aid type of way that we sometimes only have the privilege of making, but I hope in the structural ways that will make a long-term difference. And that really leads into the work that you're doing today, that we are not just in, let's dream up the new innovations for the next budget phase. We are in, and I tell this to my agency team all the time now, we have so much that we have been gifted, and now it's a chance to be responsible with those gifts and implement them to the best of our ability with all of you, not just at our side, but helping us lead the way. So with that, Kim, I'll turn it over to you. I'm sorry to take a few extra minutes to go through that, but really, really great to be with you just for a little bit.
Thank you so much, Secretary, for that welcoming message. And the only thing I'll add before we do our introductions is just, it does feel like, I think this is not just me as a parent, but back to school season. I hope you, by that I mean two things. The implementation that Mark mentioned, that is now time to get out our pencils and get to work implementing all these initiatives, but also in the sense that I hope you had a break since the last time we talked. I hope you had some sense of summer despite all the challenges that we're all facing and continuing to navigate together. And it is so good to see all of you. So I'm going to ask Maria to go through our roll call. As you might remember, we are a large and diverse advisory committee, so it's 5 whole slides. As you see your name or hear your name, could you please turn your camera on so we can try to associate names and faces to the best of our ability? But otherwise, Maria will lead us through it.
Thank you, Kim. Committee members, again, just please say hello or present or here when you hear your name being called for roll call. And I'd ask you to please excuse and feel free to correct any mispronunciations. We'll get it right next time. We'll start with Eric Harris.
Here.
Claire Ramsey.
Here.
Valerie Agostino. Okay, Valerie, hearing none. Patricia Blaisdell.
Here.
Great. Mariva Brown.
Good morning, everyone.
Good morning. Michelle Cabrera.
Good morning, everybody.
Hi, Michelle. Erica Cassow. Erica. Nina Weiler Harwell.
Present.
Hi, Nina. Jessica Cruz.
Good morning, everyone.
Good morning. Jared Giarusso.
Good morning.
Morning. Sherry Farina. Sherry, are you here? Liz Fuller. Lisa Gonzalez. Gabe Griffith.
I'm here. This is Lisa.
Oh, hey, Lisa. Thank you so much. We'll note that. Gabe Griffith.
Here.
Great. Gail Groner. Joanne Handy. Actually, I think that's Eric. Eric Dowdy.
Right, that's
That
our,
is Eric. Good
one of our
morning, I'm
corrections,
here.
Eric Dowdy. Yes.
Thank you.
Got it. Thank you, Eric, for joining. Barbara Hanna.
Good morning. I'm here.
Susan Henderson.
Hey there.
Michael Humphrey. Michael. Okay, hearing none. Corrine Jones.
Greetings and salutations.
Hi, Corrine. Kathy Kelly.
Good morning.
Good morning. Eileen Coombs.
Good morning. I'm happy to be here today.
Thank you. Sunny Madden.
Good morning.
Shireen McSpadden. Shireen. Peter Mendoza.
Peter Mendoza here. I should mention my employment affiliation has changed. I recently accepted a position with the State Council on Developmental Disabilities as a community program specialist in the Sacramento office. However, today I'm here solely as a consumer representative who receives service. Great to be here with you all.
Thank you so much, Peter. Kim Mills.
Here.
Lydia Miselitis.
Good morning.
Morning. Martia Moto.
Good morning. Hope everyone is well.
Gabriel Rogan.
Here, good morning.
Michelle Rousey. Michelle, are you with us today? Okay. Katie Shinoda.
Good morning, everybody.
Richard Smith.
Good morning, everyone.
Morning. Sarah Steenhausen.
Good morning. It's great to be here.
Robert Taylor. Robert Taylor. How about Greg Thompson?
Good morning.
Hey, Greg. Janie Whiteford. Janie. Kate Wilbur.
Good morning.
Hello. Sylvia Yap.
Happy Thursday.
Hey, Sylvia. Alana Yorkshire.
Good morning.
Good morning. Glad you're with us. Kim, I know you're here. Thomas Aragon. Thomas.
This is Dr. Rohan Radhakrishna filling in for Tomas Aragon from the California Department of Public Health.
Thank you so much. I've made a note of that. Nancy Bargman.
Yes, good morning.
Lourdes Castro Ramirez.
Hi, good morning. Melinda Grant, Undersecretary here on behalf of the Secretary Castro Ramirez. Good morning, everyone.
Thank you so much, Melinda. We'll make a note of that as well. Stephanie Clendenin. Stephanie, are you with us? Okay. Secretary Mark Galley's here. How about Vito Imbasciani?
Secretary sent regrets.
Thank you, Kim. Kim Johnson.
Good morning.
Morning. David Kim.
Similarly, we're going to do it. Secretary Kim and his team asked for, we'll talk about this later, but couldn't come today.
Got it. Okay. Director Will Lightbourne.
Good morning, everyone.
Good morning. Julie Sue.
We will update this slide as well. She's been appointed to a federal post. I don't know if we have a labor agency rep here today.
Yes, Abby Snee, Deputy Secretary of the Labor Agency.
Thank you, Abby. Welcome.
Thank you. Thank you, Abby. Vance Taylor.
Hey, good morning, everybody. It's Vance. I'm on.
Hey, Vance. And then Joe Xavier, last but not least.
Good morning, everyone.
Great. Thank you all so much. And I think that concludes roll calls. Just want to check, are there any other committee members present who were not called? Fantastic. Director Wade, back to you.
Thanks. And I just want to check in with our team. I'm hearing from the public that the public view isn't always following the yellow box. So if we can just confirm that, of course, we have our interpreters pinned, the slide visible, as well as what I call the yellow box. There's probably a better word for that. So I have the privilege of doing some very brief committee updates. In particular, I want to mention that we, with a committee this large, we have some new particular members that I want to just lift up. You already were introduced to them. For AARP, Nina Weiler-Harwell is joining us. So thank you, Nina. And for Alzheimer's Association, Jared Giarusso is joining us. So welcome, a special welcome to Jared and Nina at this table. And we will continue to have some additions, I believe, on the County Human Services side with Shireen McSpadden's transition from aging to homelessness, although still very much community living. So more to come. And please do reach out if there are other updates or additions that we need to make for your organization or community. Since we last met, I want to thank you all for the input and the work with Claire and Eric. To remind you that the purpose and scope, the charter, is posted on our agency webpage, and it really does try to lift up and build on the values and the progress of the Olmstead decision, be person-centered, equity-focused, and data-driven in our work to advance home and community living choices. We decided operationally that we should meet quarterly. And we're going to try a format this time of one half of the meeting being a deep dive on a community living topic, and the other creating space for hot topics, because meeting quarterly, in this time in place, there is a lot happening. So we're going to try that today. We thought the first topic for this meeting made sense to be the new proposed Home and Community-Based Services Spending Plan, thanks to the extraordinary federal opportunity and leadership of DHCS and the Secretary and all of my department colleagues in the legislature's partnership. So we're eager to hear from Director Lightbourne, who is standing in for JC, big shoes, but I'm sure he can do it, to give us an update. And then we'll hear from you all. We've heard loud and clear that the most important thing at this meeting, while we do want to have that common shared information, is to have time for dialogue and discussion. So we tried to build in much more time for committee discussion and, of course, public comment. We're proposing for our topic for our next meeting in November, TBD, housing. Housing, of course, is critical, and it's another area of major leadership and partnership and innovation. So that's our current proposal, and we are working with Eric and Claire's leadership on finalizing an agenda for the next year, so you can get those dates on your calendar, and we can have some time to prepare those topics, both having those locked in topics, and then again, that hot topic forum, if that format works for us today. And we'll tweak it if it needs improvement. Anything else, Claire and Eric, that you think we ought to add in terms of overall operations before we turn to the topic at hand?
Oh, this all sounds good, Kim. Thank you.
All right. Well, then without further ado, Director Will Lightbourne from the California Department of Healthcare Services to lead us in an update and overview of the historic, dare I say, Home and Community-Based Services Spending Plan.
Well, thank you very much, Kim, for the introduction. Let me try to sort of situate the Home and Community-Based Spending Plan as we have it proposed now in the context of what seems to be emerging as the federal government's vision of HCBS activities. As you know, within President Biden's the $3.5 trillion budget reconciliation act, he has at different points proposed something like a total of $400 billion to expand home community-based services. We'll talk a little bit in a moment about sort of how that is being understood definitionally. In terms of sort of where the construction of the reconciliation bill now is, as you know, it's passed the House day before yesterday. It is not sort of what passed is sort of a superstructure of the details. So now it moves to various committees in the House to sort of start to fill in what are the component details of the reconciliation bill. And when they're sort of done with that, it then moves on to its own path in the Senate, which is, has a number of unknowns attached to it, including, sufficient votes and consistency between them. But in some respects, we have been looking at what was in the American Rescue Plan, which is what we're talking about today, as being a sort of a down payment on that larger HCBS vision of the Biden administration. Technically, what was in the American Rescue Plan was a provision that allowed a increase in the federal matching rate on a list of home and community-based service programs that states currently operate. The value of that increased match would be calculated over a one-year period, and there was definition offered as to what did qualify and didn't to earn the match. Once that match is calculated, it's an unusual federal match increase in that it becomes as though it were actually state general fund dollars. And the significance of that, of course, is that as state general fund dollars, that increased revenue can be used for expansion of home and community-based services activities within guidance offered by CMS. And to the extent that the services that are proposed or the activities that are proposed are Medicaid eligible, they can then further draw matching funds from the Medicaid program. And so in that sense, it becomes very fungible state funds that can be used to further grow the pot. The spending plan has to, as I said before, fit within a broadened definition federally of home and community-based service activities. And the condition for receipt of those funds is they must be fully expended or returned within a 4-year period. And additionally, within what is understood as the home and community-based services programs that have earned the increased match, there cannot be a reduction in those programs or benefits within that window of time in which the funds are available to the state to spend. So it is intended as a growth opportunity for HCBS and not a supplantation wherein states can sort of reduce their current footprint or their current spend. When CMS released the guidance for how to, we knew it was in the American Rescue Plan, which passed very early in the administration. However, CMS did not release the guidance for how to calculate the savings and how to develop spending plans in relationship to it until literally May 13th, the day before the governor's May revision budget was released. So the HCBS spending plan is largely outside of the budget process that was adopted. I say largely because in dialogue with legislature, some items from budget were moved into it, but it was not itself considered in the budget process. The total amount that we calculated that California can earn through the increased FMAP is slightly over $3 billion. Now, depending on what we propose to spend those funds on, that can, again, as I mentioned before, in some instances, draw further federal participation from the Medicaid program. The federal definition of home community-based services that the federal government moved through the American Rescue Plan and their instructions were very broad and speaks to a perspective that really embraces, I would say, health and social care in a very progressive way. It is not a narrow set of services. And it with a goal, I think, supporting programs that themselves support healthy living in communities for those who cannot live healthy living in communities without additional interventions or services. So, for example, and very significantly, it would include services to allow homeless people who would not otherwise be living safely in community to be served and transition to community living as an allowable activity. So when we sort of had the federal instructions and had our calculation of potentially what the investment fund could look like, we sat down with our colleagues in the CHHS agency, the various departments, to sort of really sort of start to think through a state plan to draw and spend the funds. And as we approached that conversation, and DHCS, because we're the Medicaid agency, sort of coordinated the process, we sort of identified several principles that we thought had to be sort of at the heart of what we were doing. We wanted to be sure that we were furthering the policy goals and commitments of the Newsom administration. Some of the activity that has already been developed through the Master Plan on Aging, the CalAIM initiative, the administration's very firm commitment to equity and closing disparities and outcomes. Secondly, we were mindful that these were one-time funds, and thus it was sort of essential to focus as much as possible on building the infrastructure in the home and community-based service system, not exclusively, but with less emphasis on creating activities that might sort of be stranded after the 4-year period if general fund budget capacity wasn't available for them at that point. And third, and this sort of related to the infrastructure thinking, was to the extent that we could anticipate or predict what the home and community-based service investments downstream that the Biden administration is going to be sort of bringing forward through the reconciliation bill. We wanted to be sure that our development of infrastructure or readiness or preparation was anticipatory of that, and so our systems could maximally benefit from and participate directly in the sort of expanded HCBS opportunities that we think, you know, there's a strong possibility are ahead of us. So as we worked through what we saw as being the important components, we really identified 5 categories of spending activity that we thought should be emphasized. The first one was relating to workforce, the home and community-based services workforce, both from the sort of perspective that we know it has sort of carried a lot of the burden and suffered from the effects of the pandemic, that a lot of folk have been worn out, burned out, et cetera. And so making sure that we're making investments to retain people who are still in our workforce. Also sort of making sure that we are looking to how we build the workforce going forward, not just retain the current, but build in the future. The second program area that we wanted to focus on flowed quite a bit from some of the discussions last year when we were charting the sort of the overall home and community-based service system network and recognizing that it was very complex. It had multiple aspects to it. And from the point of view of the consumer beneficiary, it was not easily navigated. And so we wanted to be sure that we were addressing the needs for navigation resources in the HCBS area. Third, and very centrally to the whole concept of home community-based services, we wanted to be sure that we strengthened transitions. In other words, being sure that as people's needs are changing or their care environments are changing, that the resources are available that allow them to be living in community. And so whether that's hospital to community, SNF to community, interventions sort of along those lines, we wanted to be sure that we were building that capacity. Fourth area that we wanted to focus on was enhancing the service system, the capacity and the models of care that we have, and being sure that we're sort of exploring alternatives that we might not yet have had on the table. And then finally, looking to simply the infrastructure of the home and community-based service system, what was needed in terms of just the, almost, if you think of it, almost like the wiring and the plumbing, what was needed there. So as we sort of developed and then sort of did, each of the departments sort of had lengthy consultation with the stakeholder groups that we normally engage with, and particular attention to the constituencies that have been brought together around master plan and Galley, et cetera. We sort of started to frame a plan with funding components. Now, as I mentioned before, this was occurring outside of the budget process, but of course we worked very closely in partnership with our legislative partners. So as we were sort of framing out the detail of a spending plan, we also were engaging on what their priorities were and things that they wanted to be sure were sort of embedded in this. So when that was complete, that took us until early part of July. On July 12th, we submitted a spending plan to CMS for their review that totaled about $4.64 billion. So in addition to the original $3 billion in the FMAP bump, we were looking at another $1.5 billion in potential matching FFP for activities that were Medicaid eligible. No, we have not yet heard back from CMS with their any questions or concerns or comments that they have on our spending plan. We know that pretty much 50 states were submitting. A number of states submitted earlier than we did, and that CMS is sort of working through on a flow basis. We would anticipate that we are, however, within weeks of being able to engage in detail on it. If there are areas that they, in our spending plan, that they feel fall outside of the guidance or the allowable guidance, or where they feel we are seeking further FFP that may not be eligible, then what we'll have to do is sort of regather with all the people we talk to and see if there are ways to refine any specific proposals to fully meet the CMS requirements, or if we simply need to swap something out because it's otherwise sort of not allowable. What I'd like to, I don't want to read the whole list of what's in the spending plan, but it's posted on the DHCS website. You can sort of read in detail, but just some sort of highlights to give folk who may not have yet read it a feel for the kinds of things we're trying to do. So in the workforce support area, a significant commitment of resources to through CDSS for not just retention payments for IHSS caregivers, but also creating IHSS career ladders. Funding to expand the clinical HCBS workforce is provided through Hcbs. Support for workforce who are serving the homeless is included through DHCS. In the sort of navigation space, resources for no wrong door types of technologies and systems in Department of Aging, dementia education through DHCS, language access, cultural competency, development and training through DDS, Department of Developmental Services. In the areas of sort of transitions, very sizable investments in residential pilots that DHCS will be working with CDSS and Department of Aging to sort of frame out and design and implement. Elimination of the assisted living waiver wait list is included in the spending plan. And then again, access and cultural competency services. Additionally, through DHCS, further incentives for housing and homeless services to move that agenda forward. And then in the services area, enhancing services for the elderly in the Department on Aging program, coordinated family support services and DDS, significant investment in social and recreational opportunities for regional center clients, and significant investment in implementation of developmental service rates, obviously in DDS. In the infrastructure, looking at things like technology and data transparency in the existing programs, and then developing technical access for seniors and people with disabilities, investments being sort of led through the Department on Aging. So those are the kinds of activities that are sort of featured in the spending plan. As I said before, we don't yet have CMS approval on it. We expect to be moving in that zone very soon. And then what we would be doing is starting implementation of the activities as soon afterwards as system readiness was available. We're not waiting for a specific future budget date or something. So with that, let me stop and turn it back over to you, Kim, and see how we want to proceed.
Terrific. We do, excuse me, we do have one question that came in from the Q&A that maybe you could give a brief answer to. How does the current home and community-based services spending plan align with the goals and objectives of the California's Home and Community-Based Services Transition Plan? If you prefer to hold that, we can. But
I'm sorry?
If you prefer to hold that, we can, but I'll give you a chance to address that.
Yeah, I mean, I think it very closely aligns, and that was one of sort of those background conceptual documents that when we said we were aligning to the administration's policies, including that.
Terrific. Okay, well then let's go to the next slide, and I am thrilled to hand it over to Claire and Eric, who are going to facilitate committee discussion. And thank you for your prep to do so.
Thanks, Kim. If we could go to the, well, actually, let's stay on this slide for just 1 second. So our next section is really going to be a committee discussion. And I am going to present a very short slide on each of these different topics that Director Lightborn has gone over. We're going to talk first about workforce, then we're going to talk about navigations and transitions together. And then after the break, we'll talk about the services section and the infrastructure and support section. So we'll have a chance to really have commentary on all these different pieces. So I'm going to do a very short one slide, just sort of reflections, and then Eric will add any of his thoughts, and then we will turn it over to the committee. So hopefully you will all be thinking about the different pieces and how they're going to impact the community you're working on behalf of, or for the services that you provide. So could we go to the next slide? So these thoughts that I'm going to go over were really from pulling together the former Master Plan for Aging LTSS subcommittee, which many of you are actually on this, the DACLAC committee as well. And so these were just some thoughts to get us started, kind of some overview thoughts of the plan. And we're really excited, I think, to see such historic investments. I know that word has been used several times, but honestly, I don't know how many of us can actually think of a time in our careers when working on these that such a huge amount of money has been poured into Hcbs services. So on the workforce side, you know, some of these things will probably feel very resonant for most of you. The LTSS subcommittee, you know, wanted to just recognize the huge need for workforce investments. Provider shortages have just become more and more of a real problem in all aspects of direct care. And so that, you know, figuring out solutions to this problem is just absolutely critical right now. The subcommittee really felt strongly that we needed to both think about career advancement and career ladders, which is, you know, a piece of this, but just to be very mindful that if we're too sort of focused on getting people sort of out of direct care and into other forms of work, that we're going to make our work shortages even worse, so that it is critical to retain and expand the number of direct care providers. And there really was a sense that this HCBS spending plan was really investing in that, both the retention and expansion piece, as well as thinking about were there further opportunities for people who might want to progress out of home care or direct care and into a different field, but related, you know, healthcare or some licensed category. We also wanted to acknowledge that the one-time funding is extremely helpful because it allows us to make these like big significant investments, you know, sort of in a big chunk, but, you know, we really have to think about how to access ongoing funding to really ensure higher wages and benefits long-term. And as Director Lightborn referenced, some of those potential ongoing opportunities are going to come from the federal government actually making that historic $400 billion investment into home and community-based services that is sort of moving forward through Congress right now. So with that, I want to see if Eric would like to add anything on workforce, and then we'll open it up for committee discussion.
Thank you so much, Claire. The only thing I wanted to add, you know, DRC, one of the things that we've really been focusing in on when it comes to the workforce development and these really monumental investments that have been put into the system is how impactful that is going to be on the disability community, on individuals, on consumers, and on families. And, you know, we have been advocating to make sure that these increases across the board, rate increases in the IDD space, other systems really have a direct impact and really are connected to the individual and the outcomes that we're looking for when it comes to improving their outcomes for work and improving their outcomes for finding housing. So we really do think that this is going to be such a benefit to the community, to so many people. And we're trying, Claire, myself, we really want to encourage discussion so that we can ensure that the agencies, the directors, all the folks all the staff know exactly what the disability community is asking for, know what the disability community needs. So then when we look back, when we kind of go through this and then look back, we're able to know exactly what worked and then what we still can find improvements on. But we feel enthusiastic about this investment in workforce development, and we look forward to finding out more from you all, how you all see this working out.
And with that, I see people are starting to raise their hand, and that committee members, just to be clear, we will have public comment at the end of this HCBS spending plan discussion. But members of the committee who want to speak on workforce should start raising their hand. Like I said, we will have opportunities under each category. So if you really want to talk about navigation or services, that's coming up. Oh, and great. I was just going to ask if we could remove the slides. And so I can see people lined up. So I'm going to start calling on people in the order I'm seeing them in line. And if Maria, it turns out that that's a better job for you, just let me know.
And Claire, similarly, I'm just going to give you that we'll probably want to do about 10, 15 minutes on workforce, and then we need to move to Nat. Yep. Okay. Thanks.
Perfect. Thank you. Let's start with Janie.
Thank you. Janie Whiteford here with California IHSS Consumer Alliance. And we are very concerned about workforce development. We know that so many of our consumers are not getting the providers right now that they need. We anecdotal evidence of folks having to stay in bed because they don't have any providers that are available for them, particularly on the end of high-end users. So we are very concerned that when we look at attracting workers, that we have a look at differential pay rates for those that work in the workforce with high-level quadriplegics, high-level folks that have vents, that type of thing. It's a totally different workforce that we're looking at for those folks than we are looking at for seniors that just might need meal prep and that type of thing. So I think differential wages is a huge issue. I also am looking at workforce and retention. We know that we have consumers that cannot maintain that. It's just like an ongoing cycle of getting new workers in, and that 30% of folks that are, that don't have family providers. We would really like to see some of this money spent on consumer education. We feel that would be really effective, and people that come into IHSS, and I think in other programs too, do not understand what that program is about, do not understand what that program provides for them and what it does and does not provide for them. And so I think that's one area that we need to have consumer education right on when they come into the program. Providers have they have to look at a webinar when they come into the program. Consumers, it might be a good idea to have them just look at a webinar as part of their introductory program, because we know a lot of times social workers do not explain adequately what the program is all about for a lot of consumers. We also know that consumers you're not a born manager. And in all these programs, you are required to manage, fire, train your own provider, which we think is fine in a lot of cases if you understand that system. So we would also like training for these folks to get a little bit of an idea of what it takes to manage and work well with their provider so that you don't have this tremendous turnover. We also are, as I said, very concerned that with the career ladders that you're going to be losing providers. So there has got to be some way that incentivizes providers to stay with IHSS in some of these lower jobs that go into a CNA or a LVN or something like that. Okay, that's it. Thank you very much.
Thanks, Janie. I really appreciate your comments. Greg Thompson.
Thank you. And Janie, I appreciate your comments, and we'll probably be echoing some of those. I wanted to speak just to what Dr. Lightborn said. I really appreciated hearing about these opportunities we have, but when I hear the word infrastructure, it scares me a bit. Maybe I don't fully understand what that means, but I think we know what the problems are. And so I really encourage us to try to get the money to the problems, and that would be to the actual work. I'll speak specifically to IHSS, the IHSS consumer and the IHSS workforce. Career development, I think, is extremely important. And if we're talking about, the biggest thing we're hearing is people on the program are not excited about training IHSS workers to lose the workforce. So if part of this funding is going to be for IHSS career development or career ladders, I think we need to consistently use that language, IHSS career developments, so that people will stay in IHSS. As far as the provider shortage, again, we've known about that for years. I can point to the California Auditor Controller report last year. Los Angeles County did a report in 2016 that clearly identified that the IHSS recipient who does not have a family provider struggles to find providers and keep providers. So I really think that that's a priority. And the last, people experiencing homelessness. What we've noticed in LA County, it's really difficult to find a provider for somebody that's on IHSS, for somebody that's experiencing homelessness. We really need to improve the communication and work on that. So thank you.
Thanks, Greg. Marty Emoto.
Marty Emoto, family members, City Can. First of all, thank you for doing this. Thanks to Secretary Galley for your update, Director McCoy-Wade and Director Lightborn. And I do have a question for Will. If there was like a 30-day time period for CMS to respond, I think, to the states, I think that was probably a loose deadline, but I just wasn't sure if CMS ever responded saying, it's in the pipeline. And then the other thing on the workforce issues, I echo everything that was said by my colleagues. And thank you, Eric and Claire, for your summary of that issue. Before I go on, and I'll be really, really brief, I just want us to remember someone who really worked hard on all these issues, Charlie Bean. He passed away in July. He was a tremendous advocate for people with disabilities and seniors. He's a person in a wheelchair, but he was the previous chair of the California IHSS Consumer Advisory Alliance. Tremendously good individual. And, one of the things and a friend to many of us on this Zoom meeting, and I will always miss him and his humor and his strength and his vision and his fight for all the things that we're talking about today. So I just hope we remember him, his life, everything he has done, and also his family as we're talking in the rest of the day and as we're working in the rest of the coming months, because ultimately everything we're talking about is about a life, and Charlie Bean's life really did make a difference for all of us. And on the workforce, I'll be really short, that when we talk about it, it needs to be person-centered. So it kind of does link back to what Jamie and others have said, but it needs to be person-centered. Because just because a person might just need meal prep or certain minimal services in the home, it doesn't mean that those aren't vital to their existence or mental wellness or behavioral health. I have someone living with me who has Down syndrome. He cannot live alone. Now, but he doesn't have severe physical problems, but he would be in danger if he was left alone. And I'm an unpaid caregiver. He used to have IHSS. So we need to think of things in a person-centered way, which actually is the agency is focusing on that, and person-centered outcomes, because when we apply resources, we got to make sure it works. Lastly, the issue of the shortage of the workforce, we have to think creatively, because it's not just us. It's everywhere. It's restaurants. It's the healthcare nurses, doctors, teachers, truck drivers. So if the shortage is happening everywhere, whatever problem we come up is going to have to realize that and figure a way out. How do we incentivize people to come to home care and other services that people with disabilities and seniors and people with mental health needs, the blind and the deaf, what services they need. Because this problem is much larger than just our system that we talked about. And so the whole idea is lifting ourselves out so we're not thinking of just silos. We're thinking of the person and how do we get help to that individual. And so that was a long way of asking a question to Will. And thank you to everyone.
And I want to make sure right now I have 6 hands, and I think 7th popped up, and I want to be done. We need to be done with this topic by 10:10. So if people can keep their comments to 1 minute, and I appreciate that so much. And next is Kim Mills.
I talked pretty fast, so I think I'll be under one minute. I appreciate the committee's recognition that we are in a crisis. I'm a provider at Better Life Together, provider with the San Diego Regional Center. And it's critical. It's great that we had the Burns and Associate rate study and that there's some plans to implement it starting April of next year. The crisis is now. And is there anything we can do now to assist us in providing higher wages to the people that for staff? And I'm excited about the pathway for professionalizing the position of the direct support professional, and the recognition that it may not be as simple as, engaging with community colleges, and that I would propose that providers probably can provide some of those trainings as long as there are competencies that we can establish as a community. That's it. We need help now. We can't serve people without staff. And so our agency is not that large, but we are effective, and we receive referrals, and it's really disheartening that we can't provide services, so people's needs aren't being met. Yes, we need a workforce, but I just want us to make sure we're focused on the needs of the people that we all provide supports to. They can't be served, and that's a real crisis. Thank you.
Thanks, Kim. Next, Lydia.
Hi, everyone. Echoing my colleagues' comments, and Kim, great segue to what I was thinking. We have an urgency right now, in particular because of the vaccine mandate for healthcare workers and the testing mandate that also cuts across healthcare and social service providers. And we're already hearing reports of people quitting just because of the testing mandate. And we're also hearing reports that there will be staff leaving due to the vaccine mandate, in spite of the exemptions for religious beliefs or medical reasons, which I believe are fairly limited. So we have an urgent problem right now, and I worry a little bit about waiting on CMS to approve the plan, given Mr. Lightbourne's description of, the queue, if you will, of reviewing all the state's proposals. And I'm wondering if there's a way relative to the spending plan, where I noticed there's $100 million budgeted for, it looked like one-time grants to providers to retain staff and certification training and so on, if there's a way to expedite that funding. So for example, for those who have to seek replacement staff, signing bonuses, for example, just ways to get people interested in working in our field that maybe have not before. And this is, to me, not something that can wait until January 2022. We need to be thinking creatively right now so that we can not only retain the staff we have, and we do need to increase wages across the board, but also to attract new people into our field, because it's such a rich, rewarding field. But we've got to do something about potential staffing shortages right away, because it hurts the consumer. The person who's receiving services is the one that's ultimately going to be hurt. Thank you.
Thanks, Lydia. Abby?
Sure, thank you. I want to talk about the labor agency's perspective and partnership, and how much we appreciate very close partnership with CHHS, with the Department of Aging, the priority of the labor agency, and coming out of the Future of Work Commission recommendations around ending poverty with a focus on care on the care sector is really to look at building ladders and raising floors and improving job quality in this sector. Really appreciate the recommendations and some of the discussion on career advancement and improvements to wages and quality and the impact that career advancement might have on keeping the workforce robust and stable. There has to be a both and strategy. The jobs and the wages have to be improved, and we have to keep building the skills within this workforce. Really appreciate the suggestions around wage increments for specialized training, and just keep remembering the impact of a highly skilled and well compensated workforce on quality of care and outcomes for those recipients of care. And the only other thing I'll say is that the governor's California comeback plan and the state budget this year also included significant investments to the labor agency and our departments for skills training with a high road and job quality focus, and are working with Department of Aging and other partners within CHHS to leverage those resources as well for training. Thanks.
Thanks so much. And Peter Mendoza?
And thank you. And I'll just be brief. First, I want to honor what the state's doing to really advance community living and many of the proposals. And we all support caregiver equity. I do want to draw attention a little bit to what's been said about the shortage of caregivers, because it affects many of us. And there's many of us. I'm lucky I have privilege, so I have resources I can pull on, but it's still difficult. Many of our brothers and sisters don't have those resources, and they're feeling depression and in some cases suicidal ideation because they're having to give up eating and drinking sometimes because they don't have enough caregivers, for example, to assist them with activities of daily living. This is a major problem. It's also a major problem even for me. Even though I have systems, I get my home care through the regional center system. I've been looking for a weekend care staff for a few months now. And recently I had someone who left, and then I had someone who went on vacation. And so my backup person for the backup person had a family emergency and couldn't work a shift, which left a family member to do my home care routine. The family member has disabilities himself and experienced great pain having to help me. This is not something, this is getting tougher and tougher as time goes on. So while I applaud workforce innovation and many things we're doing, we really need to make sure we're tracking the availability of the workforce to make sure that people don't leave direct care programs, for example, CHHS and other related programs. And also, we need to have a serious conversation about backup services. I worry, I just turned 55 years old and I have a really active and wonderful life. And I honor the system and everyone who supported me in that process and my family. But as I get older, this is going to be harder to manage.
You're right.
Thanks, Peter. Christina Mills, sorry.
Thanks, Claire. I won't echo everything that Greg and Janie and Peter just shared, but in addition to that, I think under the backup system that we really need to prioritize, and I know the state tried to move in that direction during the pandemic. I also want us not to forget the backup that's needed during a disaster or a natural disaster or emergency, other than our providers not showing up. So I think that needs to be a part of that discussion too, because we've seen during the pandemic people not showing up, but we also see in the wildfires people not showing up to provide the services and care that an individual needs. Wages, of course, are critically important to our community in the independent living centers. And then the career ladder development, I just want to say that, you know, it would be, I think it would be a step in the right direction to partner with the independent living centers. And I can't recall which of you said it, but independent living centers were required to be made up of 51% people with disabilities. And we are consumers. And some of us are providers as well. So being able to provide those trainings and development opportunities as a part of the career development ladder, I think would be really helpful. And then the last thing I want to say is, if you don't know, CFILC's Disability Organizing Network program is doing an IHSS series right now. We just did our first one last week on how did we get here and how do we move forward. Our plan is to obviously get people grounded in how we got here, but also where do we go moving forward to make the system more functional for people with disabilities and older adults.
Thanks so much, Christina. Nina.
Hi, good morning, everybody. I'm going to try to be uncharacteristically brief. I really appreciated this conversation because ARP has been interested in the IHSS career ladder proposal, but hearing the additional concerns around, pardon me, around the impact on the IHSS workforce was an important one. It was an important learning for me. I want to raise up one other thing. I heard one commenter make a comment about differential pay. And so I don't know if that pertained to differential pay for backup providers versus everybody or something else. ARP, absolutely. I will say that ARP is very open to examining living wage proposals regarding all IHSS workers, family or non-family. But at some point, I would appreciate some clarification.
Thanks, Nina. And we're going to end with Barb. Hannah.
Thank you. Thank you to all of my colleagues. I concur with all of these comments. I want to just throw out some ideas. We've talked about where do we find these workers. And I think that partnering with our high schools, starting young, because we need to start getting people interested in this field. And it would be a wonderful opportunity to take a look at workforce development, similar to what the ROP programs did. Equally, another group or population that we may be able to tap into are the older adults themselves that perhaps have retired but want a second career or are interested in doing something else. I think there's a group of people that we may be able to tap into. And thirdly, the DD population. There are those that work in our communities right now, and there are certain tasks that, and I know we've done this before, there's other programs. I want to say down in the Bay Area, I think Jonathan Istrom and the Independent Living Center out of Alameda, I think, actually did some work on utilizing DD clients, but they also became employed. And so it's looking not at the traditional workers that we currently have, but expanding that and looking at different ways of putting populations together. So I'll leave it at that. Thank you so much.
Thank you all so much. Kim and Eric, I want to suggest, what if we took our 10-minute break now and then we don't have to, we can just make sure that we get through the other three, but don't have to sort of break it up. Would that work for everyone?
That's a great idea.
Okay, great. So when we get back, we'll talk navigation and transitions, and then have time for the next two categories. So Kim, do you want to call the break? I don't want to.
I will indeed. We're going to move our break 5 minutes early. 10:15. We will come back at 10:25. Please do mute yourself and turn your camera off so we can each have the break, and they'll see you back in 10 minutes. Thank you so much. I'll start welcoming us back after break. We'll go back one slide before the break because we're going to talk about navigations and transitions. Perfect. I'll do a quick agenda update. Claire and Eric and I are so grateful for the discussion we've been having, but also are watching the clock. So we're going to try to have a 15-minute conversation about transitions and navigation, again, with the short tee up from Claire and Eric, and then hearing from the committee. Do the same for services, and then maybe do a shorter conversation on infrastructure so that we can get to public comment and be pretty close to our planned time.
Kim, I just want to pause this really quick just to kind of flag that we don't have ASL interpretation. I think.
Okay, I see Brenda.
You see Brenda, okay.
Hi, Brenda.
Got it, okay, thank you so much.
Okay, Maria, are we back with the public and with our interpretation?
Yes.
And I'm turning my captioning back on, so good to go. Okay, Claire and Eric, take us to the next topic, transitions and navigation, please.
Hi, everyone. Thanks for coming back. So as Director Lightbourne mentioned, transitions and navigations are actually two separate sections within the Hcbs spending plan, but we thought it made sense to sort of combine them and talk about them together. And again, these are sort of the reflections of the LTSS subcommittee on sort of what is included in the plan and sort of how it helps us advance our larger goals. First, I think people are really cognizant of the fact that, we have a huge Medi-Cal system for Hcbs, but that there are also a lot of people who can't access Medi-Cal because they're not eligible. And so that people really need, both people on Medi-Cal and people not on Medi-Cal need navigation and transition options that may not be easily solved within a Hcbs spending plan that's wrapped around Medicaid funding, but just something for us to think about when we're creating a California Hcbs system. Next is sort of a clarification of intersections between other efforts, especially CalAIM, which is going forward right now within the Department of Healthcare Services and has a lot of potential to help people with these particular issues, but helping us as a stakeholder community and then larger out to the consumer community understand the connections between CalAIM and other existing services and new services potentially being offered through the Hcbs spending plan. And then lastly, running through all of this, I think people, very clearly pointed out, Marty talked about person-centered. I think we also want it both person-centered, but realizing people are different, needs are different, but people should all equitably have access across the state to transition and navigation. So how do we create some consistency to make sure that people really have good experiences regardless of where they're living in the state and whether in urban or rural areas, whether they're in higher income or lower income areas. And so those were sort of our initial thoughts. Eric, do you want to add anything before we start having people raise hand to comment on this? And please, if you want to raise your hand, go ahead. I'm sorry.
No, thanks, Claire. Just real quickly to kind of piggyback off of what Claire was talking about. We do, think it's so important to include as many options as possible because, as Claire mentioned, you're going to have a bunch of different intersections of where people are located, rural and urban, intersections of income levels, intersections of just circumstances that people are living in, and of course, the intersections of cultural differences, race, different income levels, all the different levels that Claire brought up. And we're trying to make sure that all the decision makers understand that people are not in kind of a straight kind of lane, a straight cookie cutter lane where it's easy to pick someone up and place them into one circumstance, but that everybody's in different and unique spaces. So I'm glad that you brought that up, Claire, but yeah, we can go ahead and have the conversation.
Thanks so much, Eric. And as I was saying, if people want to start raising their hand to get in queue, they can. And first person up is Richard Smith.
Richard, you're still muted. Still muted, Richard.
Richard, I don't know if you can hear us. You're muted. There we go. I think that's it.
Better? Okay.
Yeah, perfect. Sorry about that. Thanks.
No, I'm sorry about that. Yeah, I kept punching the microphone and nothing happened. So clearly that doesn't work all the time. I just want to mention one thing that we have been, our organization, Independent Living Partnership, has been highly focused on, since 1993, maybe before that, and that is transportation, equity in transportation. Across, including rural, including urban, including people with disabilities, including people who are disadvantaged, lower income people, people with a lot of physical inabilities or mental inabilities that they're dealing with. So what, I'd like to mention to the committee is that the base case for the best case profile of effective transportation service is that it's able to provide a level of service that meets the rider's requirements wherever they are. It's available when needed. It goes where the rider needs to go when the rider needs to go there. It is within the reasonable capabilities of the rider. Riders accept the service, the image that they display when they are using that service, the comfort, the safety, and the main thing is it's affordable. And if you look at what's available now for our disabled and elderly population, sick population, there's public transit, fixed route. There is, of course, a paratransit service, which for many of our clients is not affordable and not easy for them to use because of their disabilities. There's taxi service and there's ride sharing, and there are limitations with those things. So, and then there is the volunteer driver option, but the main thing that I see there that's a problem is that there is not stable funding for it, that there is not adequate funding for it, and that it's thought of, even though it's conceivably the third leg of the stool of transportation that's needed, it is regarded generally, in my view, as not being worthy of sufficient and regular and reliable funding. So that's just what I would like to say this morning. Thank you.
Thanks, Richard. And Corinne Jones?
Okay, I'm trying to unmute. Yeah, I wanted to tag on actually to what Richard was saying. As far as recognizing and being very, very conscious of rural needs and issues, the services and the needs here in the rural communities are very, very different. We have unique problems, and those need to be considered. Transportation, as Richard had spoken about, food insecurity and food deserts, access to medical options and services, along with the direct service and service provider issues and concerns. I live in Ukiah, a city of about 16,000 people. During the normal week, we have more that come in. We don't even have an urgent care center here. You want to have urgent care, you've got to drive to Santa Rosa, which is an hour drive. Those are things that are that need to be sourced out, brought out, recognized, and be part of this as we go forward, because the area is not going to not grow. It's just going to continue to be deplete of the services and issues and things resolved that we need. Thank you.
Thank you. Kathy Kelly. Or did Kathy just put your hand
Yes,
down?
I lowered my hand, but it was just a question because we're on navigation and transitions, correct? And the
Yes.
information that's available. And it's just a question about structure of this. And that is that there are, of course, differences and preferences for the way that people access information around these issues. And I'm assuming it's both going to be something that is available by phone or by online access. And there's going to be some thought about how to structure a pathway for people to look at the best collection of services or recommendations about the services needed. So.
Thanks, Kathy. And I see Kim McCoy-Wade vigorously nodding her head. So, and then Nina.
Hi, everybody. Great comments. I just want to second or just hold up what Richard had to say about transportation in rural areas. Absolutely. Corinne, speaking of Mendocino County, my husband and I have explored that county, possibly thinking about retiring there. And I'll just say, as somebody with 2 autoimmune issues, he has a heart issue. We had to just rule it out. There's just not ample services there. I think in Mendocino, there's 1 hospital. You would have to drive all the way to Santa Rosa to get anything, which is something like 2 hours. So that is absolutely a concern. I did want to raise up, and Kathy, thank you for your comments as well. I do want to mention, when we're talking about transitions and really no wrong door, just at some point want to hear how this will plug into the no wrong door system being developed led by the Department of Aging, so that everyone everywhere can get the services they need where, how, and when they need it. I'll also call out, and I'm not saying that this is absolutely, the end of the conversation, but the LTSS subcommittee report, as I recall, we called for 12 discrete core services for any kind of no wrong door LTSS system. So again, really appreciate the comments and happy to be part of this conversation.
Thanks, Nina. Sylvia.
Hi, speaking of transitions, I also want to mention that they are extremely extra expenses for us. I work for Friends of Children with Special Needs nonprofit organizations to really prepare for reopening or all the expenses. And thinking about transition, I think Hcbs should also include that extra expenses for small organization can really get ready to protect our staff and also the disabled people we serve for their health. And this kind of thing is not just the mask or the cleaning supplies, but also the facility readiness, the air box that we need to clean on that. And speaking of transportation, that, in the past, we can put 6 people in the van. Now we can only transport 1 person because of the social distancing. And so please put that into consideration as well. Thank you.
Thanks, Sylvia. Sarah?
Thank you so much. Thank you for a great conversation and appreciate all the insights from the members. A few themes that I'm just noting that I think kind of arise in all of this, which is, just ongoing issues of capacity and access to services, whether it be knowing about how to access the services and the information and support behind that through the no wrong door system, but also ensuring that we're not in a situation where a few years down the road after these important one-time investments have been made, that we don't then have kind of a cliff where we lose access because the investments are no longer there. So my question is, in thinking particularly about pilots like the community-based residential continuum pilots, once the pilots are nearing their end after 4 years and the funding is no longer there, I'm assuming there will be some sort of evaluation and consideration of how to build the successes of that model into the system. And that would go for, I'm sure, other pilots as well. And I think that also ties to just thinking of other opportunities. Nita, you mentioned the issue of the core service mix. And that's something that's highlighted in the Hcbs gap analysis and roadmap proposal that was just approved by the feds under the Money Follows the Person supplemental funding opportunity. So that's a separate opportunity outside of this Hcbs spending plan that I think really complements a lot of the work in all of these proposals. I'm thinking really kind of long-term about what's the roadmap for Hcbs services, where are the inequities in the system, and how can all of this help kind of meet the goals of the roadmap. So I would love to hear from Will or anyone about kind of what your thinking is about evaluating the range of these opportunities and what the next steps would be after the funding is used up after the 3 to 4 years.
Thanks, Sarah. And what I'll do is, if it's all right with Director Lightborn, I'll give him an opportunity to sort of close us out and see if there was any sort of things he wants to touch on right at the end before we go to public comment, just so we can make sure we get through everyone's comments and all the pieces. And Janie, you get the last word on this.
Thank you very much. And I want to give a big thanks to Marty Emoto for remembering and in memory for Charlie Bean, because he was our executive director and we miss him dearly. I just want to open a big picture here, because I'm talking about those folks in the gray area that are not Medi-Cal eligible, that have to draw down their funding to become and I'm thinking, why does this have to happen? You know, we need to find some way that these folks, that those of us that pay privately, which is me, and spend a lot of money for our personal care. And the only thing that I can see, as I said, I'm opening a huge big door here, is Medicare for all. And I think we need to look at this big picture somewhere as we look, because there's a lot of folks that are not Medicaid eligible that are really going to be, as we age, looking at these issues and needing the care, but having to pay privately, and it's going to really impact a lot of us.
Thanks, Janie. Appreciate that. All right, can we get the next slide up, and we're going to move on to services. Thanks so much. And we can keep going to the next slide. Thanks so much. So just quickly, again, the services category was quite broad within the Hcbs spending plan. And Sarah just mentioned this, but I think one of the things we wanted to think about was the intersections between things like the new Hcbs roadmap that just got approved, CalAIM, the spending plan, other efforts that might be have been pushed forward through the budget, which are really important, and how these things are all going to work together to really, again, create a system of Hcbs within California. And I think this is, again, like sort of a really unique opportunity to do that and to do some of the high level thinking about how we create that system. Next, just how important it will be for ongoing funding to continue past the ends of the American Rescue Plan Act funding. And that was sort of talked about right at the beginning too, like, can we get that $400 billion approved within the federal budget so that we really are talking about sustained investment in Hcbs, and to Sarah's point about not falling off of the sort of cliffs when pilots end and things like that. Also, people really wanted to be thoughtful about balancing new investments and sort of innovative ideas and sort of the things that are sort of on the horizon with funding for existing programs. Because we do have a lot of programs and a lot of good things happening in California, and how do we continue to build on those and strengthen those while also realizing there might be new things we need to start or gaps we need to fill. And then also want to just call out that, you know, at some point we're really going to have a discussion about rates for providers and how that will impact access to services. And Eric, I don't know if you want to say any more about the DD piece. I know you mentioned it, but I think that's, you know, in the non-DD system, that's a conversation that we haven't had as much.
No, yeah, I know I mentioned it earlier. It's an important issue that I know a lot of consumer advocates, a lot of family advocates, and providers have been working on and fighting for a really long time. So to see the investment this time around has been encouraging to a lot of folks, but some people are still in kind of a wait and see mode where they still want to kind of see how this is going to play out and how it's going to positively impact the community. So we're really hoping that discussions like these ones can encourage and inform decision makers, and really making sure that that all of these processes improve for folks who need it the most.
Thanks, Eric. And if people want to start queuing themselves up for this conversation, please do. And I also want to mention something that was pointed out to me that wasn't on the slides, that I think is another piece that should be raised, is just how COVID and which is still ongoing, and you know, how that's impacting how services are delivered, what just to Sylvia's point, how services might be more expensive to deliver, and there's more requirements on the provider. So just not losing sight of the fact that we're still mid-pandemic and there's going to be services are going to continue to be impacted by COVID. So with that, I want to start. Christina, you're up first. Mills.
Thanks, Claire. This is Christina. I just don't want us to forget the impact that we've been working towards and really building through the Aging and Disability Resource Centers. Those are truly, you know, our no wrong door systems right now as they stand. And some of the AD, while it's still very new in a lot of ways, we're really fortunate in California to have disability and aging be the core lead partners. That's a requirement in our state that's not in any other state, which means that the ILC and the AAA must be the core partners. And with those that have been in place a little longer than others, it's been really exciting to see them invite their DD partners to the table and to have the regional centers participating in that. I appreciate what Eric had just said about the DD community and just want to make sure that we are not forgetting the DD community as we move forward in creating and furthering the ADRC agenda and no wrong door system. I'm going to go on that as one of my priorities, but I just have to say beyond that, that I think we are also still doing a disservice to families and children too. And while the systems may look a little different, kids with disabilities grow up and adults with disabilities age, and we age into more disabilities. And it's a continuum of lifespan services that we need to work towards in our ADRC and no wrong door systems.
Thanks, Christina. Erica.
The Commission on Aging recognizes the historic and unprecedented investments in home and community-based services, infrastructure, and direct care of workforce in both the state budget and proposed HCBS spending to support community living goals outlined in the Master Plan of Aging. We commend Director Lightburn and Chief Deputy Director J.C. Cooper and staff for pursuing enhanced federal funds to improve, enhance, and expand HCBS in California with a continued focus on person-centered and equity-focused services. We are excited to see significant investments in the Commission's top 5 priorities: the development of innovative model to increase access to and coordination of long-term services, LTSS for all Californians, such as California Advancing and Innovative Medi-Cal AIM initiative, the creation of a public LTSS benefit, expanding an aging disability resource connection, no wrong door model, supporting the establishment of the California Elder Justice Coordination Council, and partnering with the California Department of Aging on California for All Ages campaign supporting inclusion and equity and combating ageism in California. As a provider and a direct line worker in long-term care, prior to COVID, there was already a 30,000 shortage of healthcare workers. We understand completely that we are in the midst of a crisis in caregiving, insufficient workers available to providing care across all settings, and especially acute and long-term care settings. We recommend providing similar training and incentives for in-home support services and adult protective services, social workers. We wholeheartedly support one-time only investment in older adult resiliency and recovery to shore up historically underfunded essential services at both the state and local level. This includes senior nutrition, senior employment, falls prevention, and family care resources centers and more. Support investments in Elder and Disability Justice Coordinating Council. Given the disproportionate impact of COVID on the health and mental well-being of older Californians, we encourage to see the proposed investment in behavioral health form line. And just as a line direct provider and administrator of the long-term care and a CCRC here in California, you know, we have incentivized our workers to stay home, and I'd like to see some incentive to get them back to work, including to provide those programs that we all need in place to develop our next workers, to get them excited to come back to our profession. We need everyone to support us, and I really appreciate the time and topics that are being discussed, and I am in total agreement that we cannot wait till January or another moment to not come up with solutions for what we need today. Thank you so much for your time and for having me on the call.
Thanks, Erica. Greg Thompson.
Hi, thank you for taking my comments. And I want to speak specifically to systems, and with all due respect to all of my colleagues on here, I think that I would like to propose that we look at what Olmstead is about in ADA and serving low-income people with disabilities, and start to implement these systems from, I'll use the term, from the bottom up as opposed from the top down. I've been doing this for a while, and it seems like, there's so many bright people and so many good ideas, but every time we form a committee or come up with a new idea or a new plan, it sort of delays the process. And I'm just really concerned that people with low income, disability, people who are struggling and aging, it sort of blurs the line, and we forget about meeting their needs first, and they sort of get pushed to the side or forgotten about. I acknowledge there's so many problems to solve and so many things we want to do, but I really would like to see this committee and the state commit to really attacking the provider shortage and providing care to the low-income, elderly, seniors, and people with disability who just can't get out of bed or out of their house without a proper caregiver. Thank you.
Thanks, Greg. Marty Emoto.
Thank you, Marty Yamamoto, family member, CDCAN, California Disability Senior Community Action Network. Just want to say I echo, my support, or actually underscore my support for the words that were said all by my colleagues, including Sylvia, Eric, and Christina, and also Greg just now. But I really want to also underscore, though, the need as we're moving forward with all these different initiatives that we go back to the Health and Human Services guiding principles, which actually are really spot on, and people should read that. It's only one page, but it talks about whole person, looking at things in a whole person approach, whole person care, but also supports. And that ultimately, and that is why the Hcbs spending plan, at least the initial one, and even the revised version, was so transforming, or potentially transforming, because implementation means everything. But we need to remember, if you look at the whole person and then link it to person-centered planning, person-centered advocacy, and then person-centered outcomes, then it does address the issues that Claire looking at individual needs, because if it's person-centered, you'll do that. The reason why I'm really stressing whole person is that we got to get out of the silos. So when we talk about the DD community, of which I'm a part of, through my sister and all through the person that I'm providing care for, unpaid here. But that person, my sister she was in the mental health community. She was in the behavioral health community. She was in the Medi-Cal community, in the IHSS community. She was a person that needed all those things and regional center services. And the thing is, if we keep thinking of people in communities rather than the issue that people need, we're gonna end up losing people, and we're gonna end up still siloed. When we talk about housing, it should be every one of those individuals, people who are deaf, people who are blind, people with developmental disability, everyone, seniors, everyone needs a house, everyone needs healthcare, everyone needs food. Someone raised that issue earlier about food security. Everyone needs transportation. And so, and some element of our population needs employment. We can't speak of communities as much as we think of individuals and people, because then we won't forget them. We will forget them if we only think of the various traditional communities that we've been wedded to in the past. As advocates, we have to change too. We have to think of the issues, and then we got to think of the whole person. My sister had mental health issues. She had behavioral health issues. She had physical health issues, and she had developmental disabilities. Which community did she belong to? Guess what? She's a person. She needed all the help that she has a right to have, like any one of us. Anyways, and by the way, when we finish with this, I'm still looking at Will. So whenever you're able to answer them, that was it. And by the way, I gave you a really easy question too. And thanks, appreciate the conversation.
Thanks, Marty. And don't worry, I'll let Director Lightborn speak again. Jared.
Thank you. I wanted to take this as an opportunity to just, one, express our excitement for what was in the HCBS spending plan and in the budget this year, and how much is dedicated to individuals with Alzheimer's and dementia. I may have missed the opportunity to talk about Dementia Aware on the navigation portion, but really wanted to highlight this program in the HCBS spending plan as, you know, a huge barrier or huge challenge for individuals with dementia is receiving a diagnosis. Less than half of individuals in California, of which there are about 700,000 individuals in California living with dementia, have that diagnosis. And we, the Alzheimer's Association really believes that this is a positive thing to receive that diagnosis. It helps individuals access care services. It helps them with life planning, gives them an understanding of what's happening for them and their family, their caregivers as well. And Dementia Aware hopefully really fills a gap currently in that ecosystem of services that help individuals receive a diagnosis. Right now, if you're in Medicare, you hopefully receive cognitive screening through the annual wellness visit. But in California, individuals over the age of 65, there are about 180,000 individuals in California without Medicare who are only Medicaid eligible. And so something like Dementia Aware really fills that gap for that community of people. I'd also want to mention on the services side, how excited we are to see the funding for the Alzheimer's Daycare and Resource Centers, particularly now at a time when isolation is a huge challenge for individuals with Alzheimer's and dementia. And so being able to see what that might be able to provide for people is something that we're really happy to see.
Thanks, Jared. And Sarah, you'll have the last word on services.
Okay, just one question and a comment, in particular about this nursing home innovation and recovery $2 million investment, which I think when we think back to the whole impetus for the ARPA HCBS investments, it was responding to the tremendous challenges that COVID brought about in our congregate settings and in nursing homes. So just want to underscore how important this sort of investment is. And I'm cognizant of the fact that it's $2 million. And yet when you read what this effort and initiative will try and do, it seems that that's a lot to do with $2 million. So I would love any information on what the vision is for how those funds might be utilized at this point. And then just couldn't help myself in making this comment. The first version of the HCBS spending plan, I just wanted to highlight one proposal that was in there that I think was talked a lot about in the LTSS subcommittee that has such merit. And if there is ever a situation that we find ourselves with any other funding that could be made available, I think one key element in helping transition people from institutional settings to the community and in helping divert people from having to move into institutional settings is a sort of fund that can be used in emergency situations for one-time needs. And it was called the Community Living Fund, and it would have been, as it was described in the original plan, operated out of the Department of Rehabilitation in partnership with the independent living centers. I think that something like that, an investment, can go a long way in kind of bridging a gap for a lot of people who are at risk of institutionalization, as well as people who really need to transition, and it could supplement funding available through the Money Follows the Person program. So those are just my comments. Thanks again for a good discussion.
Thanks, Sarah. And I'm going to move on to infrastructure. We're going to keep this one pretty short. We have about 7 minutes to wrap this discussion up, and then I'll turn it over to Kim and Director Lightborn for last words. Could I get that last slide up about infrastructure? Thanks so much. So last, I'll just say the infrastructure and support pieces, I think people were really excited again about having dedicated one-time funds. Often infrastructure is so hard to find funding for. So people were really excited about access to technology because it's crossing all aspects of people's lives and vital for community living. The LTSS data, there was a point made about how it should be linked with other efforts, including CalAIM. So I know that's a theme that we've seen, linking efforts together. So it isn't, to Marty's point, creating more silos. And then nutrition infrastructure, how really needed this funding was, and how big of a difference it's going to make for people to have that real targeted investment to nutrition. Eric, anything you want to add there?
Yeah, just quickly, I think, in the work that we do, a lot of the clients, a lot of the consumers that we work with and folks in the community, when they hear infrastructure, I know somebody mentioned earlier, it kind of brings a little bit of concern or fear in some ways. And I think it's just because, explaining exactly what infrastructure means to each individual person is so important. Marty mentioned, individuals need so many different things oftentimes. And so I think that this is going to be really helpful in kind of diving into an explanation of what infrastructure means, especially depending on the disability, depending on the needs of the person and of the family. So, I'm looking forward to this conversation as well.
Great, and we're going to kick it off with Pat Blaisdell, please.
Thank you. One area that we don't usually think of as infrastructure, but I think it is really part of the critical linking that needs to happen between medical services that may be covered by CalAIM, as well as long-term services and supports, is greater attention and assurance for access to rehabilitation services, both when someone's making a transition from a care setting to the community, or if they're in the community. There's a real problem with Medi-Cal beneficiaries in general being able to access formal therapy services like physical therapy, occupational therapy, and so on, that can greatly enhance their ability to live more independently, and also access to programs integrated with that, exercise programs or activity programs to help maintain mobility and self-care at the highest level possible. So it's a key area of integration as well as infrastructure that I want to make sure from our standpoint is a really critical piece in ensuring the success of the integration that we're all looking to provide.
Thanks, Pat. And Sarah?
Yeah, I just wanted to make a small shout out, or big shout out actually, to how exciting it is to see the LTSS data transparency proposal. I recognize that the funding got reduced from the first round to the second round of the spending plan, but it's a tremendous step forward. I want to particularly call out my colleague Kate Wilbur from USC, who has been really a leading voice on the need to develop a better, more comprehensive integrated data platform for LTSS. And I think that this proposal is really the first step to getting us a long way there, especially when you think about it in the context of the DHCS Population Health Management Service and all the wonderful data that will come out of that. There's just so much to talk about, and I hope that we have opportunity to kind of consider all of these initiatives, the data initiatives together, because it'll help, I think, really inform smart policy making when it's eventually implemented.
Thanks, Sarah. And Lydia, you'll have the last word on this one, and then I'll turn it over to Kim and Director Lightborn.
Okay, thank you. Well, really spot on with the infrastructure discussion here. There is existing authority in law to fund startup grants for adult day health care centers around the state, and we've lost a lot of access, particularly in rural and semi-rural communities in California over the last 10, 15 years. So it seems like this might be an opportunity with one-time funding, especially to activate that law and get some startup grants to local communities where they could start up a program. And then, of course, once it's started up, the funding stream is available through managed care. So this seems to also dovetail nicely with the start of CalAIM and opportunities here to really build a robust community system, which is a major goal of the Master Plan for Aging. So perhaps there's an opportunity to do that. It seems like a great use of one-time only funds. Thanks.
Well, I want to thank Claire and Eric for an incredible job facilitating really rich discussion. I took a ton of notes for the Department of Aging. But before I say a full thank you, I want to give Will a chance. There were some questions, Will, about CMS status of approval and coordination with CalAIM and the roadmap. So give you a few minutes to speak to those and other questions you heard.
Sure. Thanks, Kim. First, really enjoyed the conversation and the questions and the suggestions. I mean, this is obviously going to be a very iterative process. And as we receive approvals of things, we'll be sort of engaging, all sorts of stakeholders in some of the detailed rollout work. Not to immediately answer Marty's question about CMS, but to build off his earlier comment about sort of whole person care. That is the context in which I hope we're sort of looking at everything that is sort of unfolding at this point. I mentioned that the Hcbs spending plan is sort of largely outside the budget, but it is, if you sort of look at it and map it, it is completely consistent with the huge initiatives that are sort of coming through the budget at this point. Probably for me, at least top of mind, I mean, CalAIM, which is a whole person, whole system care approach with, Sarah was just saying, population health management instruments and data systems, sort of serving the in lieu of service suite of services that our managed care plans are going to be bringing up, including things like recuperative care, medically tailored meals, et cetera. All of these are sort of packaged in. And when they sort of look at CalAIM with the master plan on aging, the fact that in this budget, we sort of begin the ending of the asset limits for Medi-Cal for seniors and people with disabilities. The sort of Office of Medicare Innovation and Integration that's starting up, the huge investment in the behavioral health continuum infrastructure, $2.5 billion to build out the missing pieces in the behavioral health system. All of these fit together, I think, with the home and community-based services spending plan. And when we sort of chart it to get, it's a little mind-boggling in terms of all of the interactive pieces, but it really is a whole, and it was totally driven from the notion of whole person care. In terms of the timing with CMS, CMS says a lot of things can be done in 30 days, and I can't think of one that ever has been. So we are, however, we are at this point daily conversations with CMS around various parts of our waiver activity and other things. I don't have a doubt that they are moving on this expeditiously, and I really expect to see feedback in the next week or so. We're not waiting for that feedback, however, to start a lot of the implementation work, some of which may have to change gears a little bit, but the departments are working together and with their stakeholders as we speak for system readiness, particularly around the workforce piece, which is such a central part of the conversation today. It is so essential to this, to the whole dimension. And frankly, it is one of the huge drivers behind the Biden administration $400 billion Hcbs proposal, is the recognition that we have to have a whole new workforce available, and it has to be treated differently than it has historically been treated, both in terms of its compensation and its opportunities. So I would just situate that there. Finally, to Sarah's question about how do pilots continue? To some extent, as I said at the beginning, we're hoping that we are focusing pilots in places that the larger federal investment in Hcbs positions us to continue. But also, yes, we will have to evaluate these things to be sure that they're basically doing what we hoped they were doing. Now, in the case, for example, of the alternative residential systems and plans, if they're successful, we should see really savings in the long-term services and supports services spend, which is in the same agencies. But frequently when we talk about sort of offsetting savings, they're in different agencies. And so you never get to calculate them in one place. In this case, I think we are sort of to the extent that there are actually savings, in addition to improvements in people's lives, we can calculate them. And particularly since we're bringing LTSS into the managed care plan benefits, in a couple of years ahead as part of CalAIM, it'll be relatively, I think, doable. If the pilots are working, we'll see the results and be able to sort of capitalize them out going forward. So that's my hope. And this has been great fun and I've enjoyed it. And it's obviously the beginning of a conversation and not the end.
Thank you so much, Will. I will kind of mirror your remarks on the behalf of the Department of Aging, how helpful this has been as we move into implementation on the direct care workforce in partnership with CDSS and labor agency and all agencies. We'll be leading, as you know, from the budget, the 150 million direct care workforce, and are beginning to talk and think more about how to do that in responsive to all these concerns and have a stakeholders table to continue to deepen the focus on that. So more is coming, but as Will said, we're not waiting for CMS approval. The ADRC work continues. I hope many of you were at the our No Wrong Door. The 101 webinar yesterday had, I think, close to 400 attendees and is recorded. And of course, the advisory committee continues to meet. We just received our HCAP, our Medicare Counseling Strategic Plan, and we'll be presenting that to the HCAP stakeholders in September. And again, Alzheimer's Day, moving to roll that out, adult family homes, extending it to older adults from the successful IDD model. So thank you for the partnership with DDS. Nutrition infrastructure with the AAAs, digital divide with the counties. We are moving ahead on all fronts and are thankful for your continuing input here and at those specific tables to get it done right and get it done in an equitable, person-centered and coordinated way. What I'd like to do is open it for public comment. I think if we do about 10 minutes, we'll see. We'll be close to on track. And we'll have plenty of time for hot topics. Maria, if you can help us with that. I see 2 hands raised. There may be others.
There are about 4 hands raised, and I know we've got lots of items coming in through the Q&A. So maybe we can start with those that have their hand raised, and we'll sort of bounce back and forth between the two, see how many things we can capture in 10 minutes. So Sari, I know you've had your hand on for a while. Do you jump in? Sari Tatpaporn?
Yeah, hi. Can you guys hear me?
Yeah. Mm-hmm.
Yeah, first of all, I would like, my name is Sarita Papon. I'm currently the Executive Director of the Able Community Development Foundation. So I'm 65 years old. I'm a senior myself. I'm a consumer because my mom is 84 and had a disability. My son, 43, he's also had a mental disability. So I'm from Laos. I'm part of the Southeast Asian refugee immigrant who settled in this country back in the early 80s. So now the first generation, many of us become a senior, and we have to cope with aging issue, disability issue. So I just want to bring the issue of what's going on in our community, mainly the Laotian, the Hmong, the Cambodian community in the state of California, especially in Northern California. So we have the office in Richmond, California, but we have the network in Sacramento, in Stockton, and Fresno. So we have lots of problems, but one of the reasons I decided to get involved, or I decided to take over the organization a couple of years ago, is simply because I had seen a lot of issues and problems affecting our community. So I just want to make a comment and bring the unmet need in our community to your guys' attention as part of the group of people who have the mandate to work on the aging and disability problem in the state of California. So technically, I'm very glad to participate in this meeting. This is my first time, and I'm looking for some assistance and some partner to try to help my community. And because, like I said, I'm a senior myself. My wife is senior. mom, 84, senior disability. My son had mental disability. And throughout this struggle in the past, I had learned there's a lot of problems happening in our community. So I just want to thank you guys for working on this kind of issue. Thank you so much.
Thank you. I'm going to read a public comment from Maxwell Hellman. Besides increasing hourly wages for direct caregivers, workers need more stable and consistent hours, schedules, as well as benefits as healthcare, more paid time off, pensions, etc., to make it a sustainable job. How are these needs being considered? Thank you, Maxwell. Pamela, let's open your line.
Thank you. And I want to say thank you to everyone who's working on the committee. I'm a recent retiree, really not by choice, but this is a area that's very, very concerning to me. Being an African-American woman over the age of 65, I have a disability and I'm a female. So I have like 4 layers of a lot of biases in terms of me, keeping a job, looking for a job at 65 and having the feeling that I can still contribute to exactly what we're doing here. I am currently a PhD fellow. My specialty is in systems, and I'm doing research now looking at how can we collaborate and coordinate systems because the whole is greater than the sum of any part. So I hear what you guys are actually saying in terms of we have all these parts, but we need to look at the person as a whole. So I really like the concept of no wrong door. And my concern is if we're at base camp right now, and we have a lot of startup projects coming, you know, people like me who've been in the field for many, 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 many years and serving communities and underserved populations, if we're at base camp, can we bring in some of these people who have, you know, recently retired or retired, who are professionals, who have developed programs, to be able to really see when we leave base camp, are we going to get halfway up the mountain and figure out, okay, hey, who has the flashlight? No, I thought you had it. No, I thought you had it. And we get halfway up, but we don't have everything we need to get to the top of where we need to go. So I hear all this wonderful news about the funding that's coming out. But one thing we have to remember is that if we're not using the money wisely, we're not looking at qualitative and quantitative analysis of how we're using the money, it's really going to affect the people that we serve. Because for me, I'm finally realizing that at 65 years old, I'm not giving the employers supposedly what they're looking for. But for me, I believe that I have a lot to offer. I have a lot to contribute to new build-up organizations. So why can't we have a pool to pull in some of these retirees or people who have 30 years of implementing programs and, you know, to sit on panels, to be able to provide feedback, to go out into the community to see how these programs are being developed and what can we offer, what can we contribute to making it sustainable. Because for me, again, at 65, I have layers and upon layers of disparities and isms that prevent me at age 65 from getting and keeping a job. So I'm really glad to see that this is going on. It's only been a couple of weeks that I haven't been working, so I'm looking at different committees and what's going on in my community, what's going on with the senior population. And just to end on the note, I have been a provider for my sister until she was not an IHHS provider for her for many years, until she could not, it was too much for me. And I'm currently now taking care of my son who has a disability. Both of these were family related, but I can definitely see where there are some changes that need to be made at the lower level. Because when I call into in-home support services, I don't want to be treated like, everybody who's in this career is one type of person, and I'm going to put you in this bucket. And that's what I have experienced. So with that being said, I would just end on, it would be very difficult to convince me to be a in-home support service, person who would want to build an organization or to collaborate or put out be able to have a company or whatever in that field, just because of the experience that I had on a phone call. So I say that to say, I make myself available. Again, I have lots of years of experience, in my dissertation research right now is on systems theory. And I'm doing a phenomenological study on lived experiences of community reintegration. And I'm really happy to hear what I've heard today. But again, we're at base camp, and we want to make sure when we get up to halfway up the mountain that we have the tools that we need for us to continue the climb. But thank you very much, everybody, for all the hard work that you do.
Thank you.
Thank you, Pamela. And thank you so much for joining us. It's lovely to hear from you, and certainly hope that you'll be engaging with us in the future. I know we're a little bit crunched for time, and we've got about 3 people with their hands up, about 11 comments in the Q&A. We might not be able to get through all of them. I sort of defer to Kim on our time frame.
Maria, my suggestion would be that we try to do the 3 hands that are up. And ask each of them to do 2 minutes if possible. The reminder, this is the first public comment session that we were hoping to get comment on the home and community-based services plan or anything else on your mind. We will return to the second public comment after the hot topic discussion, where we're going to be discussing many other issues, and we will take all comments at that time, even if it goes over. I will stay, and others are invited to stay as we go over to take that. So this is just the first of our public comments. So maybe Connie, Debbie, and Martha could give us a couple minutes to close us out, and then we'll transition to the hot topics from the committee.
Fantastic. All right, Debbie, it looks like you're next in line. So we've opened your...
All right, can you hear me?
Yeah.
Yes.
Yay! Hello, everybody. I'm so happy to be joining you, and I'm happy that you figured out how to show us all the faces, because I needed to see the faces. So I have a lot to say, and I'll say it very briefly. I would like to add 15 exclamation points to Marty's comments. I would like to add probably 10 to 12 to Lydia's comments. I would like to add at least 30 to Sarah's comments about the Community Living Fund. I would like to elevate that the Hcbs spending plan did not include community-based adult services. We are like the forgotten program. I'm not sure how, because the entire state eliminated us, and then we fought back with Disability Rights California and Justice and Aging. We kicked some butt, and we lived and we survived, but we just can't thrive because we are like the forgotten stepchild. So hi, we're here. We're still going. We completely pivoted, hate that word, in the pandemic to provide services outside of our centers, inside of our centers, on phones, on Zoom, you name it. Like, we're here, we need support. We have massive staffing shortages. We compete to pay our nurses, our social workers. By the way, we have skilled nursing facility staffing, but John Muir and Sutter and Kaiser and the counties all pay more to their medical staff. So we're just constantly struggling. So hi, we're here, we need your support. Everybody has talked about this. We as human beings are the sum of our parts, and the sum of our parts are not just body parts. They're spiritual, they're emotional, they are religious, they are not, they are many, many things. What they aren't is divided into silos. And so it's incredibly important that as we build these roadmaps, we not only look at all those pieces, and thank you to everybody who has elevated transportation, and you'll hear my comments on that later when I'm not with you. But I just think that we absolutely have to look at what it takes to be living in a designed environment that allows us to live like everyone else. And it's going to be different things for different people. And I am so appreciative of this opportunity. I'm so appreciative of this group. And I look forward to watching the end of it, which I have to hop off now. But thank you.
Thank you, Debbie. Okay, Connie, your line's been open. Connie, you may need to unmute. There you go. Connie, we're not able to hear you. So I'm going to give you just a couple of seconds and maybe we can hear from Martha in the meantime. Martha, your line's been open.
Hi, good morning, everybody. Can you hear me?
Yes.
Okay, so my name is Martha Navarette, and I'm an advocate for seniors. I have run volunteer hospices. I run an assisted living community for 150 residents. And right now I'm trying to help my colleagues here start residential care facilities for the elderly. The city of Santa Paula, where I am, has 0 beds available. And I am finding that the state of California is very good regulating, but is not very good assisting. And how can we build more of these? They provide care and supervision. They provide nutritional meals. They coordinate services with a lot of other service providers, in-home service providers, hospitals, nursing homes. They provide transportation, and they do it by themselves. A lot of these homes are being sold right now. They're licensed homes that are costing $1 million now here in the area of LA and in the county of Ventura, and they're closing our licensed homes. So the state really needs to build, these kinds of facilities. Don't limit them for 6 beds. That just burns money from these providers, burns them out because they can't hire enough staff. They should be at least 15, but now then I'm trying to open a 15 bed, and I'm facing a lot of challenges with zoning with local cities. City of Oxnard, for example, City of Santa Paula, they don't want you in commercial buildings. And in a residential home of 3 beds, it's not sustainable. So we really need to look into how can we make this, which are state supported services, to be really supported. So that's my comment. And I see this need with my seniors. They can't be just independent living. There's a time where they need a team, and they are not sick to require 24/7 in a nursing home or in a hospital. They should be living with a very caring provider 24/7. So we really need to help our CFEs. That's my comment.
Thank you very much. And I just want to pause, Connie, to see if you were able to connect audio. And if not, I know you've got quite a few comments in the chat, so we'll try to get through those.
Okay, great. And we'll circle back around to more public comment in a moment as well. Can you let's open us back up to hot topics. There always are many in community living. I'm going to start, Claire and Eric, with a couple updates from the administration and my colleague Vance Taylor at the Office of Emergency Services, and then I will hand it to you and the committee for full discussion. Very briefly, just want to update, as people have mentioned, transportation is a hot topic. Secretary Kim has some proposals he would like some stakeholder feedback on. So we've asked Claire and Eric's help in pulling together an ad hoc group. So you'll hear from them in a second about how we can help connect some of you with transportation expertise with Secretary Kim to give some feedback on some initiatives that agency is considering. So thank you to the Secretary for that invitation. Second, I want to thank CHHS, Stephanie Welch, the behavioral health leader. The Behavioral Health Task Force meeting in September will have a presentation on older adult behavioral health. So more to come on that. And thank you to the master plan stakeholders for continuing to elevate what's happening with older adults and disabled adults and family caregivers, behavioral health during this time especially. So more to come in September at the next Behavioral Health Task Force meeting on older adult behavioral health. My third and final administration update is to hand it over to Vance Taylor because, of course, here we are once again in fire and drought and climate catastrophe. And Vance is our incredible partner and leader of the Access and Functional Needs Response. So Vance, if we can spotlight you, there you are, and you can give us an update, and then we'll hand it to Claire and Eric.
Thanks, Kim. I absolutely appreciate the opportunity. So as everybody's aware, a lot of wildfires going on right now. In terms of what we're looking at, there really are 12 total fires that are getting statewide and national attention. Among those are probably some names that you've become familiar with: the Caldor Fire, which is now at 136,000 acres plus. That's at 11% containment. The Dixie Fire, which is just about at 750,000 acres burned, is at 45% containment. The McFarland Fire, about 123,000 acres burned. Monument Fire, 154,000 acres burned. So you can see that the number of fires has increased, but also the scope and scale of those fires has increased. Thus far, we have, in those 12 fires alone, consumed over 1.4 million acres. In terms of what that looks like for damaged buildings and structures, it's over 2,000 homes that have been destroyed. It is something we all need to be aware of and plan for. We need to have an evacuation process in place. We need to make sure that we can get out and have accessible ways of doing so. On the sheltering side, all the shelters are integrated. All the shelters are accessible physically and programmatically. We've also received a presidential declaration for individual assistance. If you live in Lassen, Nevada, Placer, or Plumas counties, you're included in that declaration, which means you will now have access to certain services, funds, and federal, state, and local resources. If anybody has questions, I would encourage you to join at 3 o'clock today. There will be a statewide Access and Functional Needs Committee coordination call, where we will hear briefings from CAL FIRE, our partners at CDSS, the American Red Cross, and public health on everything from wildfires to COVID. And I'll put that information in the chat box. So thank you, Director Wade. Appreciate it.
Thank you, Vance, very much for your continued leadership. It is wonderful to see the network get better and better at responding, even as we have to call on it more and more. So thank you. With that, Claire and Eric, can I hand it to you to tee up the hot topics with the committee?
Thank you so much, Kim. Just to kind of give you all a little bit of an overview of why we thought that this was an important portion of this meeting. As Kim mentioned, we only meet once a quarter, and we know as co-chairs, we know that so much happens in between meetings, and it's very difficult to capture everything in the 2 hours and 40 minutes or 2 hours and 35 minutes so far that we've had to discuss. So we wanted to really give the entire committee and public an opportunity to contribute hot topics. It could be letting us know kind of what you're seeing within the communities that you all represent. It might be issues that you're seeing from a policy perspective in the state legislature or at the administration level that you just want to make sure everyone on this call is aware of. And of course, it gives us information as co-chairs so that we can circle back together in between meetings and make sure that we are capturing exactly what you all hope to have us cover. So just to give you all an example, I'm at Disability Rights California as the public policy director. And one of the main issues that we have been trying to address from a leadership standpoint is with employment, really trying to make sure that the disability community, the aging community really have as much information as they can when it comes to employment opportunities, wages, and opportunities with businesses and employers. So a couple of months ago, we had a Building Back Better Summit for diversity, equity, inclusion, and accessibility. We had stakeholders from the disability community. We had legislative leaders, legislative staff, congressional staff, and leaders. Governor Newsom was able to make some comments in a recorded message, and then members of staff from the White House on disability policy. It was a really good event, and we're really proud that we were able to put it together. But something that we want to take very seriously is the follow-up. We didn't want to just have one event where we're talking about employment opportunities, issues with employment, ranging from accessibility concerns, opportunities, and of course, wages with subminimum wage as a major issue that we're trying to address here in California as an organization, along with other leaders in the disability community. But we wanted to make sure that we left opportunities for follow-up with legislative staff, with the disability leaders and communities, so that employment, as we hope, knock on wood, as many people get the vaccine as possible and stay as safe as possible, as we hope to come out of this, we really want to make sure that the disability community is not only thought about, but leading the way when it comes to building back better for California when it comes to employment. So we hope to work with all of you. That's been one issue from our standpoint that we think is a hot topic right now. But I want to hand it off to Claire if she has any hot topics as well.
Thanks, Eric. I think I just want to say it's not so much a substantive hot topic, but just for us as a community to really be thinking ahead this fall about what our priorities will be across all these different components in the new year, and how to think about both aging and disability. As Christina said a while ago, I think our strength really has been working together and engaging both legislatively and with the administration and all the agencies. So just really thinking about what we're looking for in 2022 and how to really work on that in fall. So just another piece of the puzzle, I think, for us to be all committed to going forward. And with that, we can open it up. So please queue up in line again. And Eric, do you want to run the great thing?
Yeah, that sounds great. So the way it lines up for me, it's all kind of in a different order, but I think I saw Greg Thompson as the first hand raised.
Thank you, Eric. And I'm going to be the old guy, get off my lawn, but the hot topic in LA County in IHSS is the provider shortage. And I really strongly encourage this to be elevated. I love Marty's comments about the whole person. In fact, I loved it in 1977 when I was getting my rehab and we talked about whole person and the transportation needs for people with disability and access. And here we are 40 some years later, we're still talking about it. It's a system problem. So again, it's, we have a lot of intelligent, excellent people on this call. I was trained about data-driven, evidence-based practice, and so I get that. However, I want to see action, and I'll just reiterate the California Auditor Controller report that came out last year that clearly identified the provider shortage. What are we going to do about that today? We're always talking about tomorrow. What are we going to do about that today? Thank you.
Thanks, Greg. Next is Nina.
Good morning again. Greg, I'm glad you mentioned Marty's comment about whole person. I thought that was really important. We cannot make assumptions about people based on their income. We cannot make assumptions about their family structure. Sometimes there are a lot of people that kind of waffle between Medi-Cal eligible, not being Medi-Cal eligible. I've known people who have money who've had to spend down to qualify for Medicaid because LTSS is so exorbitant and so few people have long-term care insurance. So again, that whole idea of whole person, we're looking at the whole thing and not kind of siloing people and making assumptions about their circumstances. I do have a question that can be answered maybe later though, for the administration. As part of the ARPA funds, there was also, I think, $65 billion in county, local, and tribal funds. That some of that is really, ARP put out a report, and you can find it on our Livable Communities page. I was curious about what role, if any, the state was playing in terms of helping to moderate some of the local discussions, or at least facilitate, understanding local control, but facilitate some of those local discussions about drawing down that funding. So that's a question. Thank you.
Thank you, Nina. Marty?
Hey, Eric, thank you. Marty Emoto, family member, CDCAN, California Disability Senior Community Action Network. And I support the comments that all my colleagues have just made. And thank you, Eric and Claire, for identifying the hot topics that you put forward. One hot topic I think that kind of crosses all the issues, but does look at, again, underscoring the whole person, is when a person or a family is in crisis. And that's a constant theme that we're hearing in every system or every service that a person needs. So that when a person cannot get a provider, whether it's supported living through the regional center system or IHSS or waiver personal care services, they can't get someone in their home on an emergency basis. That is a crisis, and it's not being addressed, at least not in a consistent way. And so people are not safe, especially in the time of COVID, trying to get qualified workers, just on a day-to-day, and that's system-wide. In every system, that is a problem, and that's a crisis, right? It's a crisis to the individual and a person, and we got to figure a way out together through all the systems of how do we address those individuals or families who are in crisis. Someone who has a mental health episode or a behavioral health episode. There was a young man with developmental disabilities, but he also had mental health issues in Los Angeles who was shot because the family had no other means to get help other than call 911. And I think it was the sheriffs from LA County, showed up, and unfortunately he was shot. And that isn't the right response for crisis when someone has a behavioral health or mental health need. And so I think we just or a housing need for a family in early start. And if the family is facing eviction, they're in crisis, and there's got to be a way for us to address it. And so we got to figure a way to look at the whole person, look at how can we address crisis. Maybe we don't solve the entire transportation issue, but let's solve the transportation issue for those people who are in crisis, to underscore the views of Debbie and a few others, my friend. So whatever we can do, it needs to be person-centered. We need to tie it to outcomes to those people so that we can see that when we apply a solution, we can replicate it and scale it. But anyways, it's people in crisis. Thank you.
Thanks, Marty. Gabriel?
Hi, Gabriel Rogan from North Bay Regional Center. For us in the North Bay, it's the workforce crisis, as it is everywhere. And I've been thinking a lot about something that was said earlier about, on the one hand, we've got a severe workforce crisis. On the other hand, we've got a large population of people with disabilities who are eager to find jobs. So how do we be more intentional about putting those two things together? We're going to try to do that in the North Bay, but I think to the extent we can be more systematic about it across the state, I think that would benefit everyone. On that note, I think it was mentioned at our first meeting, we might have the opportunity to break into subgroups and dive into some of these topics more deeply. That would be really helpful for me to learn from others on this committee. Thank you.
Thanks, Gabriel. Yes, we will. Claire, myself, and Kim have spoken about that, so we'll definitely talk a little bit more about that. Kathy?
Yeah. Hi, Kathy Kelly from Family Caregiver Alliance, and we're part of the Caregiver Resource Center system. We have many speakers preceding me have made reference to unpaid family caregivers, and through the process of some augmentation, we were able to speak to the kinds of issues that we're seeing in the unpaid caregiving population. Currently, we have collected a significant amount of data on both the caregiver and the person that the relative or friend that they're caring for. And this is under a formal evaluation that's being conducted by UC Davis School of Nursing, which will be available in October. But just to make just a few quick notes, is that the caregivers that we are seeing in our client population are dealing with very complex care issues. They have 90% of them are dealing with memory and cognitive issues, largely dementia focused. We are seeing, in comparison to prior years, increased levels of depression, loneliness, self-reported health is worse. And we also have seen, which is an unusual jump in those persons leaving the workforce for many of the reasons that we're all talking about. So while we talk about caregivers and reference them, we don't really actually talk about the specific issues. And what we have now is a knowable data, both in real time that we're able to share. And so I would hope that we were able to do a quick briefing or at least disseminate written materials when the report becomes available, because there's not much operationalized truly in the master plan going forward. And I think the basis of data will enable us to make better planning of this, and also the linkage between the Hcbs world as well, since 25% of the persons receiving assistance are also Medi-Cal eligibles. So I think there's a connection, obviously, and we'd like to wrap around some real data to drive those conversations forward. Thank you.
Thanks, Kathy. Peter?
Thank you, Eric. And I want to really echo what Ben said, what's up the previous speakers. You know, we as a community had a lot of difficulty during COVID-19 because many times folks were in crisis and couldn't get the support and services they needed because of lack of communication and coordination during COVID. But also that people are in crisis now. In my personal life, I get a lot of phone calls throughout the state from folks in crisis. And I recently spoke to someone who is a person with a severe disability who's undergoing cancer. It's going through radiation treatments. Unfortunately, there was an issue with getting this person transportation to the radiation treatment, and they were advised on at least one occasion to cancel the radiation appointment because the provider didn't have anyone to get them there. This person is transit dependent on an accessible vehicle. They were thankfully able to work out a temporary solution with their paratransit provider. However, I don't want to get into how paratransit works. You have to make the reservation several days in advance, and you have to keep making the reservation, and times are not always guaranteed. the person advocated for a standing ride, which is a regular scheduled ride, which is a ride, but there's a 4 to 6 week waiting list. And because of this issue, the person is, they're in a life-threatening situation. They really need their medical treatment. On top of that, their medical treatment is their right. They deserve it. And cancer and life-threatening illnesses affect everyone. So we need to be able to address these issues and have backup services when providers can't provide medically necessary transportation. That's what we're working on when the rubber hits the road, making sure people are safe and able to survive. We also need to have a discussion about direct care and caregiver stress, and also maybe a conversation about the stress that our community is facing because of the issues that folks are having to work with that are often in crisis. And again, I want to apply all the great work we're doing, but this is really issues we really need to address. Because sometimes people like me don't have all the answers, and we try to give people hope and point them the right way, but sometimes there are no answers.
Thank you so much, Peter. Next, I have Christina Mills.
Hi, Christina here. Just wanted to bring up a couple things. So I'm hoping that Department of Healthcare Services and Director Lightbourne can look into it, and that we can work together as a committee to also be a part of this effort. But one of our hot topics that we're seeing more and more of in independent living is the discrimination that folks with disabilities, particularly those with multiple activities of daily living or more than two either more than two ADLs or significant ADLs, are being discriminated against when it comes to entering recuperative care options. And so we're pursuing advocacy in these areas, but would hope that while we're pushing out CalAIM statewide, that this can be something that is addressed through that process to ensure that that doesn't continue as we move forward. And then I would be remiss if I didn't say I appreciate Vance talking about the wildfires. We assisted thousands of people last week during PG&E's power safety shutoff. I just think that it's really important that we also create space on a future agenda to talk about disaster and emergency preparedness, and that be a part of every agenda moving forward, given where we're at with climate change.
And Eric, I'm going to interrupt just with a friendly time check. If we could call on maybe Lydia, Richard, and Janie for a minute, and then I see Director Johnson has a comment, and then we need to move to public comment and next steps.
Sounds good. So you mentioned, did you say, Lydia, the comments first before we go to Ms. Johnson?
I think we'd like to hear from the committee, and then we'll end with the director. Yes.
Okay, sounds good. So Lydia.
Just real quick, I want to reiterate for us, for our community that serves 38,000 vulnerable older adults and people with disabilities throughout the state, Delta variant is our hot topic, and it will continue to be so for the foreseeable future. It's affecting all the work that's being done. We've been begging Department of Public Health for guidance, specific guidance about how to safely begin to recongregate, because that has been our goal all along. We're seeing deconditioning as we bring people back to centers very slowly and carefully. We are also hearing from caregivers about their stress level that Kathy Kelly has already articulated, as well as we're hearing anecdotally from caregivers about deaths of what I'll call despair and loneliness, because people are continuing to be isolated. We have deeply isolated our elders in the community over this last year and a half. So our hot topic, and we need help from the state experts, is COVID, Delta variant, and the future, what that might mean for our folks, especially now as boosters are looking like they're going to be available and made, well, we don't know if they'll be made mandatory, but boosters, getting people access to those, making sure that we're attentive to equity throughout the state as we try to help people, help people remain safe and get vaccinated. So that's our hot topic and really what's consuming my my work 24/7 these days. Thank you.
Thank you, Lydia. Janie?
Thanks, Eric. I just wanted to mention, like, we haven't talked at all today about the public authorities and the advisory committees. And I think, we have CICA, my organization, California Home Support Services Consumer Alliance, is really concerned with the huge change in the public authorities, where so many of them are now totally embedded in the county system. And initially, years ago, they were supposed to be independent thereof. I think when you do that, you lose the focus on whole person care. You get a tremendous turnover in directors. We see so many directors coming in that have absolutely no idea what IHSS is about or how the public authority is supposed to function. And this should be for all IHSS folks at the county level. They are mandated to have an urgent care system in place, and so many of them do not have that. I know it's difficult. I know in the rural areas it's difficult, but under the law, that's their mandate. And I know that, thank God for Greg and the PASC. Santa Clara County is doing their job, but there's so many counties that are not doing what their mandate is. And so I wonder where the accountability is. And I would really question the department to really follow through, and let's do some statistical analysis on what these public authorities are doing.
Richard.
Thank you, Richard.
Yeah, thank you. Peter, thank you for bringing up that issue about transportation. And it makes me think that we as a committee should look at the innovative and non-traditional ways that these things can be solved. Our particular organization has provided over the years somewhere in the neighborhood of 33 million rides for people just like the people you're talking about that needed to get the care. And we need to not focus so much on tweaking transit and tweaking other systems, but look at things that have worked over the years to fill in those gaps and make them work for people who need those kinds of rides. Thank you.
Thank you, Eric. Thank you for letting me kind of step in and try to land us here at noon. Director Johnson, last hot topic.
Yeah, just briefly, I just wanted to really appreciate again the conversation this morning and all of the comments that have been made, especially as they relate to IHSS specifically. I just wanted to note that the comments were heard related to the career pathways, the urgency around provider shortages, et cetera. Also wanted to make sure that everyone understood that the budget did include the establishment of a permanent backup provider system to serve IHSS recipients. And we'll be looking to work on establishing that and getting everyone's feedback in doing so. I also just wanted to highlight and indicate, based on the Secretary's comments, that we still do have resources funding to support providers to assist the recipients in getting the COVID vaccine. So just wanted to, again, highlight that that's an available resource. And then lastly, to Marty's last comments related to response and the tragedy with law enforcement recently in Los Angeles, I wanted to highlight that the department will be working on the Community Response Initiative to strengthen emergency systems or crisis response, which is really about building additional capacity for community-led interventions in crisis, especially as it also relates to other behavioral and mental health needs. So I know DHCS is also working on a number of issues on that front as well, and we'll be partnering and collaborating on those efforts, but wanted to make sure that was something that the committee and the public was aware of. Thank you.
Thank you very much. I think what I'll do now is just respect everyone's time who does have a hard stop at noon. Let me do a quick run through of what I think the next steps are, and Eric and Claire, as always, correct and add on and offer your own. This is a shared endeavor. And then we will open it up for public comment, and I invite all committee members to stay as long as they can. And we at the agency and CDA team will do so as well. And I do want to thank the many, many people who made this meeting possible, Secretary Galley, his team at the agency, many people at our department, our wonderful interpreters. Thank you so much. We wouldn't be here without you. So thanks to all of you. So our next step, we are planning to calendar shortly a meeting. We're aiming for November. We are thinking that the topic of housing and homelessness, with a joint presentation from our Business Consumer Services Housing Agency and CDSS leaders in this space, could be appropriate for November, but we continue to receive feedback on that. So look for that. Number two, I want to apologize for the many glitches in the roster. We just had a version control issue. So thank you for your kindness and patience with us. We will get that corrected, particularly Independent Living Center, who was not listed on here, Christina Mills, and our partners at the State Council on Developmental Disabilities, Rosie Ruiz. So we'll fix that going forward. Thank you very much. Rosie Ryan, excuse me, sorry. We will fix that going forward. And third, any and all feedback on the format. We had an experiment today with the 3-hour meeting, one deep or deepish dive into a big topic, and then this roundtable on hot topics. So please let Eric and Claire and myself know how that format worked for you. And as always, deep dive topic suggestions as we build out our calendar for 2022, believe it or not. With that, Claire, Eric, any other next steps you'd like to add or lift up?
I'll just say that we are going to be reaching out about the ad hoc work group on transportation, and potentially if there are interests in other topics. I think there's some thinking around long-term services and supports and around housing. So we'll be reaching out to the whole committee about that next week. So thank you for your patience with that. And we do see a lot of good work being able to be done between meetings. So.
Eric?
I'm good with what Claire just mentioned. We're looking forward to following up on the ad hoc committees. We think having some additional expertise is going to be very helpful.
Okay. With that, then I will open it up for our second round of public comment. And thank you for those of you who are here for public comment for your patience with our very full agenda. We are eager to hear from you.
Thank you, Kim. Just elevating some of the comments that have come in through Q&A and trying to summarize as much as I can. I think a lot of issues were raised by committee members as urgent or framed as crisis. And that theme is resonating through the Q&A as well. Harriet just wanted to underscore what Marty Emoto is saying about having crisis response services. Connie, lots of comments to really just elevate the workforce shortages, differential pay as real challenges. She encourages us to look at Craigslist ads and backup providers, and really just wanting to share that the emergency is now and action is needed immediately. Thank you, Connie. Bill Pelter is sharing, sort of connected to that under the radar issue, sharing a link to the aging of the baby boom and growing care gap. The report's called A Look at Future Declines in the Availability of Family Caregivers. Those who are interested, that link is going to populate in the Q&A. I'm going to read kind of a long comment from Connie. Connie, I know you're having some issues connecting to audio. If you want to connect with me offline, I can try to help you through those. Certainly would love to hear from you next time. So from Connie, those who believe the IHSS proposals were all that was needed in the MPA report are incorrect. There must be reliable and competent backup services for individuals with severe disabilities with rapid response and not overridden with rules or agency contracts with IHSS providers who do not have a clue on providing services to persons with severe disabilities. And Brenda, I apologize. I realize reading and I'm going way too fast, so I will slow down. Right now, IHSS recipients are going without care, cannot get emergency or urgent backup care, and are not receiving authorized services with no oversight and county accountability to ensure recipients get cared for. Silent voices in our secluded homes are going without full coverage, and care of those authorized services are easy to forget and dismiss. Some IHSS recipients who cannot find an IHSS provider are being threatened with and or being terminated from the IHSS program simply because the recipient cannot find a stable, dependent, competent provider able to perform the essential functions of the job for the IHSS recipient, with IHSS divisions claiming that they obviously do not need the IHSS service. A critical step is paying living wage to non-relative IHSS community care providers. And Connie does share a link to the California Auditor's IHSS report dated 2020-2019. We'll get that link out in the Q&A. And she adds, additionally, the recommendation for the California Community Living Fund is a good idea to ensure people with disabilities living in the community and those transitioning out of institutional care settings can get help with their home accessibility needs, which should include installation of roll-in showers, ceiling lifts that meet the individual's needs, special adjustable beds, ramps, grab bars, raised toilets, rotating mattresses, among other items modeled after what is done for the developmentally disabled community. All right, and I'm just gonna put that out through the Q&A so folks can access that link. Another link from Connie about new housing, rent, and utility relief programs. Bill is sharing a comment. Person-centered planning is primary importance in all of our programs and services. However, individuals exist in families and our communities, which is why ADRCs are such a critical component in identifying wraparound services for individuals and their families and or caregivers, and then assisting them to navigate the system and eligibility process to ensure those services. Thank you, Bill. I'm just going to check and see if anybody wants to make a verbal comment. Looks like we do have Vivian, you have your hand up, so we'll open your line.
Yeah, hi, I'm Vivian with Access to Independence. And I know years and years ago, because we're one of the independent living center, Access to Independence. So we do a lot of transition people from skilled nursing facility back to the community. And one of the issues that was brought to us before is to that the skilled nursing facility should should provide resources to their residents. But so far, those we haven't gotten those referrals yet. As a matter of fact, it stopped because we became the advocate for the residents. When we transition people from skilled nursing facility, if it's not a safe discharge, we talk to the social worker and tell them that, hey, these are the steps that you need to do. We are requesting funding. You cannot discharge this individual until it's a safe discharge and we find them housing or make their home accessible. But since the facility end up discharging consumers, although it's not a safe discharge, it become like an issue. Some of them, so the social worker end up not calling us anymore to help people with their transition planning. And it become, so the issue there, so the point that I'm getting at is a lot of the skilled nursing facility is not referring a lot of people to us anymore because we became an advocate that, hey, why don't you wait for this individual to be discharged until we find them a safe housing. So the point is we want the skilled nursing facility to refer people to us so that way we can help them with a safe transition. Does that make any sense? Is that making any sense? I don't know.
Yes.
Because I know before they said that they're going to do that, like give, your residents resources, whether it will be a successful transition or not. So use those independent living centers to help them with that safe transition. Since we have that funding to transition people from skilled nursing facility. We just need to help them identify what resources are available so that when they discharge, it's really a safe discharge for them.
Thank you, Vivian. If anybody wants to make a verbal comment, go ahead and use that raise hand feature. We'll kind of jump back to the Q&A for now. I think I may have maybe misspoke when I was reading Connie's comment. She wanted to underscore that she was referring to living wages, differential pay, and emergency backup services, rapid responses, which are all critical. I may have mixed those up and said something like differential wages. So I apologize for that, Connie.
And why don't we put out last call? I see one other hand, but last call, please do get in the queue or put your queue in and a question in. And so last call for public comment for this meeting. Thank you, Maria.
Fantastic. Thank you, Kim. One more from the Q&A, and then we will jump to our caller here. That we do have someone asking about whether the resources that were shared in the Q&A could be made available. So I think, Kim, maybe we can add a slide in with those links to share that out and post that to the Health and Human Services DACLAC page. Thank you so much for that suggestion. Last four digits of the phone number is 7158. We've opened your line, but you will need to unmute. We try unmuting. There we go.
Hi, my name is Michelle Rousey. I'm a consumer advocate on the committee. I just want to reiterate some of what Janie said about the PA advisory boards. They're in crisis in many counties, and there needs to be a focus on consumer voice and them given, because they not only give the consumer voice, but they also give the voices of some of the workers in a way that it represents them all in at the state level and the local levels. I'd really appreciate it if somebody could really relook at that a little bit too. And you know, the IHSS program is such an important program, and I appreciate all you guys' work today on the meeting. Thank you.
Thank you so much, Michelle. Jumping back to the Q&A, we've got a comment from Martha, who's from Santa Paula, California. She wanted to raise that residential care facilities for the elderly and adults with disability struggle with a lot of challenges, and that sometimes the state can feel more of like a policy enforcement than a partner in aiding with these challenges. So if there's any consideration or any thoughts about that, thank you so much, Martha.
Well, and again, as always, with all of this feedback, there'll be individual follow-up by respective departments on their programs, whether it's IHSS or Meals on Wheels or RCFE. But we do look forward to our next meeting in the housing conversation, including the whole spectrum of housing choices as we age and experience disability, including RCFE, assisted living, 6 beds, nursing homes, and many, many more innovations in new, affordable, and accessible housing. So we hear you. Again, thank you for your bonus 10 minutes for all of you. Really appreciate this conversation, the strategic input, the accountability, the collaboration, and the work continues. See you very soon. Thank you.